All right, folks, if everyone could please find a seat, we'll get started in a few moments. We'll let some people sign in and we'll get started. Okay, good morning, everyone. We can go ahead and get started. If everyone will please find a seat. All right, we good in the back? Excellent. All right, good morning, everyone. My name is Corey King, and I'm the Acting Health Insurance Commissioner at the Office of the Health Insurance Commissioner, oftentimes simply known as OHIC. The Office of the Health Insurance Commissioner is Rhode Island's commercial health insurance policy reform and regulatory enforcement agency. We're an agency of 11 FTEs. I like to refer to ourselves as a small agency with a big mission. And I want to just observe that it's really great to see so many unfamiliar faces. We've got a lot of people at this year's public forum and a lot of people that weren't here last year. So that's very, very impressive. This is Rhode Island's second annual public forum on healthcare spending. Last year was our first one, and this is the first public forum to occur under OHIC's new Health Spending Accountability and Transparency program. This program allows OHIC to collect data, analyze data, and interpret data on healthcare spending in Rhode Island and compare spending growth relative to a cost growth target. It's a critically important area of work for us as regulators and as policymakers because you can't improve what you can't measure. And Rhode Islanders face significant issues in terms of affording health insurance coverage and health care in many instances. So the activities that we're able to undertake in this program and the collaboration through our cost trend steering committee is critically important towards improving things for Rhode Islanders. I want to take a moment before I review the agenda for this morning's public forum to thank the organizations and individuals who got us here. First, thanks to Governor McKee and the General Assembly for funding the program. It was included in the fiscal year 2024 budget, and I consider it a very important investment in OHIC as an agency. Secondly, this work began over 5 years ago as a proof of concept. Could we convene leadership around the healthcare system to try to make change using data and using a healthcare cost growth target? And that original work actually occurred through a grant from the Peterson Center on Healthcare to the Brown University. And I'd like to extend our gratitude to the Peterson Center on Healthcare, the Peterson Milbank Program for Sustainable Healthcare Costs, and the Rhode Island Foundation for their support throughout the years. And then finally, to the people, the members of the Cost Trend Steering Committee, particularly the co-chairs, Michelle Letterberg and Al Caros, thank you for your commitment to this work, and thank you for all the time and effort that you put into collaborating with us. Controlling healthcare spending is a very important undertaking, but I want to note an important nuance in this. That's not to say that we shouldn't invest in our workforce. We absolutely have to invest in our workforce, and I'm thinking in particular primary care. If we want to achieve a healthcare cost growth target, bring healthcare spending growth in line with economic growth, we will not succeed unless we have a well-functioning, sufficiently funded system of primary care, and OHIC is committed to making that a reality. So with that, today's meeting is going to consist of a number of panel discussions. The first one, we will review our 2021 performance on healthcare spending and quality. Secondly, we'll be showing you all some new data tools, some dashboards that have been loaded on the OHIC website utilizing the state's all-payer claims database. I'm very excited about that. We'll also hear from Maureen Hensley Quinn from the National Academy for State Health Policy on pharmacy price growth and what to do about it. And then finally, we'll have a panel discussion consisting of members of our steering committee who will be addressing some of the challenges that the healthcare system is facing and some of the efforts that are underway through collaboration between the state and the private sector to try to address those challenges. Before I welcome our guests for the first presentation, I want to just say that in my 9 years at OHIC, I have always been very impressed by the fact that leaders in the healthcare system are willing to collaborate. Even with changes in leadership, all the hospital systems have major leadership changes in recent years. Even in the insurance industry, there have been major leadership changes, but this culture of collaboration has been durable. We continue to work for you, and that's something that the state should be proud of. So thank you all. Thanks for coming out this morning, and I'd like to welcome up January Angelis and Michael Baylett from Baylett Health, who will take us through our first presentation, and I'll go sit over here on the panel.
Thanks, Corey, and welcome everybody. Good morning. It's kind of hard to believe that it's been a year since we were all kind of gathered here at this very same place, talking about how to address healthcare spending and reviewing performance against the cost growth target in 2020. I'm happy to be here again, along with Michael, to present the results for 2021. Before I do that, I do want to extend a note of gratitude to the insurers who submitted data that makes this reporting possible. We realize that this is additional work for you, and we appreciate your collaboration and engagement in this effort. I also want to acknowledge my colleague Jessica Marr, who really did a lot of the validation, the analysis, and putting together the presentation that you're seeing here today. So thank you so much. So in terms of what I'm going to cover, I'm going to start by providing just a little bit of background on the cost growth target, what it is, what we're measuring, and then we're going to dive right into the results. I'm going to present the spending trends at the state and market levels, and then turn it over to Michael, who's going to go over some service category trends. He's also going to present performance at the insurer and provider levels, and then present the quality performance. Okay, so a little bit of background, which hopefully many of you already know. In 2018, Rhode Island adopted a cost growth target program through a voluntary compact to basically increase or focus attention on the problem of healthcare cost growth. And start talking about strategies to address it and make healthcare more affordable. As a reminder of what the target is, it is an annual target for how much per capita spending should grow by on a year-by-year basis. And the Cost Trends Committee first established a target value of 3.2% for 2019 through 2022, and that was based on long-term projections of state economic growth. They have since established new cost growth target values for 2023 through 2027 that are based on projections of state economic growth as well as median household income, with some adjustments made for the inflation, high inflation that we've experienced in recent years. And so when Rhode Island established its cost growth target, it was the third state to do so, following Massachusetts and then Delaware. And since then, more states have joined the effort, such that now we have 8 states in total that have cost growth target programs. And just as a reminder of what it is we're measuring and what's being compared against the target, at the state level, we're looking at year-over-year growth in total healthcare expenditures. And there are 2 components to this. The first component is total medical expense, and that is total medical expense is spending on all medical services for covered residents. That's Rhode Island residents who get their coverage through commercial insurance, Medicare, or Medicaid. And total medical expense includes sort of all claims-based payments to providers for covered services. It also is inclusive of the patient portion of the spending, so the cost sharing, as well as non-claims payments made to providers. The other component is the net cost of private health insurance, which is essentially the insurer administrative cost. And so those 2 things together make up total healthcare expenditures. Right. So when we assess performance against the target, we're doing that at 4 levels. We look at per capita growth in total healthcare expenditures in the state as a whole, and then we look at per capita growth in total medical expense in each of the 3 markets, the commercial, Medicare, and Medicaid markets. And then we also look at growth in total medical expense of insurers and providers. And so in Rhode Island, the providers are ACOs and AEs. And we do that at these levels stratified by market. So today, we are presenting the results for the 2020 performance year. 2021 performance year. 2021 will be the 3rd year for which Rhode Island has measured performance against the cost growth target. And something new that we're doing for 2021 is we're also reporting quality performance on the 7 core measures in OHIC's 2021 ACO aligned measure set. For many years now, many of you are probably aware that there's been a collaborative effort in the state to identify a common set of quality measures, and commercial insurers are already using measures in the aligned measure set to in their provider contracts. And Rhode Island Medicaid also uses these measures to determine kind of shared savings in its accountable entity program. And so the steering committee recommended that for 2021, or at least starting in 2021, that OHIC, that we report on these quality measures to complement public reporting on spending growth. So that is something new that we're seeing for this year. All right. Before we get into the actual results, I just want to provide some important context to the spending trends that we're seeing, or we're going to be seeing. It is important, first of all, to recognize that healthcare utilization and spending over the last couple of years has been really, really unusual, to say the least. We saw utilization drop significantly in 2020 with office closures and suspension in non-essential services. We also know that it's picked up in 2021 as people started seeking care again. So those things have caused a lot of volatility in the spending and utilization. We also want to acknowledge that in these years there was quite a number of provider relief payments that, unless they came through in the form of a rate increase that's captured through claims, they're not reflected in the cost trends data collection. And then I also want to kind of caution against making direct comparisons between the results that you're going to be seeing today with other analyses of spending and spending growth that are out there. There are, Corey talked about analyses of the state's all-payer claims database. EOHHS releases Medicaid spending trends on a regular basis. We also know that insurers produce reports that they provide to ACOs and AEs based on their performance and total cost of care contracts. I just want everybody to kind of keep in mind that all these analyses are produced for different purposes. They use different data. They sometimes have different populations and different inclusion and exclusion criteria on what spending to include. So we just always need to be mindful that of those differences and recognize that the cost trends results may not always align with the results of those other analyses. Okay. So without further ado, here is the big reveal. Per capita spending growth in 2021 was 3.2% for the state. So that is at the level of the cost growth target. And this chart shows spending growth over time, starting from 2019, when the cost growth target first came into effect. In 2019, spending growth was 4.1%. In 2020, it went down to 2.9. It was minus 2.9%. And then for 2021, it is up 3.2%. This is actually pretty good compared to what we've seen in other cost growth target states. In Connecticut, statewide spending growth for 2021 was 6%. In Massachusetts, the rate was 9%, and in Delaware, it was 11.2%. And then Oregon is the other state, which has yet to release its results. So relatively speaking, Rhode Island did pretty well. Total healthcare spending in Rhode Island amounted to $8.6 billion in 2021, and that is up from $8.1 billion in 2020, right? So this is aggregate spending. Aggregate spending in the Medicare, Medicaid, and commercial markets all went up. And then aggregate spending on the net cost of private health insurance went down. And as a reminder, the net cost of private health insurance is the cost to residents associated with private insurance administration. So that went down, which is sort of, I think that is in line with what we've seen in terms of utilization. It went up in 2020 when utilization went down. It went down. Sorry, did I get that? It went. Yeah, and it went down in 2021 when utilization went back up. All right, so this slide shows per capita cost growth by market, where the biggest cost growth was in the commercial market at 9.7%. So clearly, spending growth in the commercial market is what is driving overall spending growth in the state. That being said, 9.7% is far lower than what commercial spending growth was in other states. And that in other states, it was in the range of 16 to 19% growth for the commercial market. Per capita spending on Medicare grew by 8%, and in Medicaid, per capita spending actually decreased by almost 1%. This trend for Medicaid is notable, and we think it is largely driven by increased enrollment from 2020 to 2021. You may be aware that as part of the federal government's COVID response, states had to maintain continuous eligibility for Medicaid to get the higher federal matching rate. And so it is possible, and we think that many of those beneficiaries that stayed on Medicaid as a result of this policy were likely relatively healthier and didn't have a lot of utilization. So that had the impact of bringing down per capita spending on Medicaid. And it's that decrease in per capita spending on Medicaid that brought the state trend down significantly. So if we didn't have this, if we didn't have the continuous eligibility requirement, and we didn't have that reduction in per capita Medicaid trend, we would have far exceeded the 3.2% cost growth target as a state. All right, here we show trends in the net cost of private health insurance. Again, in 2020, we saw a huge increase in per capita spending on NCPHI. I think it was in the range of 14%. And so for 2021, we're seeing the reverse. We're seeing a decrease of 12.5%. And experience has shown in the recent years that NCPHI is fairly volatile. There can be large swings from year to year based on whether an insurer experienced losses from one year to the next, and then a positive margin. Or a positive margin and then losses from one year to the next. So it really swings up and down quite a bit, which is the reason that we include it in calculating cost growth at the state level, but we don't include it when we're calculating cost growth at the insurer level. We focus on the total medical expense. All right, and this slide just shows the breakdown of net cost of private health insurance trends by market segment. And so you can see that the net cost of private health insurance increased for Medicaid managed care, absent the integrity product, the duals product. And so that increased kind of profitability is consistent with having a larger proportion of Medicaid beneficiaries who don't have a lot of utilization, having them maintain enrollment in the program. But everywhere else, it decreased. Okay, so with that, I'm going to turn it over to Michael, who's going to present the rest of the results.
Morning, everyone. So when payers submit data to OHIC, they provide aggregate spending, but they break it down by service category. And the service category data gives us a little bit of insight into which services on a year-by-year basis are contributing to spending growth. I will note that each year it looks different. And so if we really want to understand what's driving spending over time, we need a multi-year look. But for at least 2021, I'm going to give you some indication of which services had the highest spending growth. So let me orient you to this graph. This is looking at where spending grew fastest in 2021 across all markets. So the size of the bubbles that you see here, the circles, the size indicates the role that that service category had to spending growth. So larger the bubble, bigger the influence. So you can see here in 2021 across all markets that hospital outpatient was the #1 contributor to spending growth. And I will tell you from having looked at data for other states that this was a trend in other states as well. You'll see that almost all the bubbles are above the line, meaning that spending growth was positive in almost all services. That's not surprising given the rate of growth that we had statewide in terms of service spending. Okay, and so by each of these bubbles, you can also see a percentage. That's the amount of growth in the category. So there might be some bubbles that are small that have high rates. That's because the base level of spending in that category is relatively low. Hospital outpatient is a category where there's a lot of spending and it grew at a high rate, which is why it's the largest circle here. What is unusual here is how small retail pharmacy is. So the last couple of years when we've shared data, retail pharmacy has been a major cost driver. That was not the case in 2021. However, if we look historically back a few years, including using all payer claims database data, we can see that pharmacy spending growth has in fact been a consistent cost driver in Rhode Island. It was not this particular year because drug rebates spiked in 2021. That might have been a timing phenomenon, that there just happened to be a lot of rebates that fell within the calendar year, but it offset the trend for this 1 year. We can also look at this by market. So this is the commercial market, and the profiles by market vary to some degree, but you will see hospital outpatient is was a consistent spending driver in 2021. So this is a somewhat different configuration, but pretty much the same tale. In the Medicare market, hospital outpatient again. But hospital inpatient, for example, was a bigger driver for the Medicare market than what we saw in commercial. The market that looks dissimilar to commercial and Medicare is Medicaid. And Medicaid's got that giant bubble that's below the line for long-term care. The reason that Medicaid's trend was negative in 2021, in addition to the suspension of Medicaid redeterminations and the expansion of the Medicaid population, was long-term care spending dropped. And in Medicaid, unlike in the commercial Medicare markets, long-term care is a very large percentage of total spending. So if long-term care spending drops, that's going to pull the whole trend down for the Medicaid program. And in fact, you can see that for all other services, trend was positive for Medicaid in 2021, as it was for the other markets. But the impact of that positive trend is diminished by the impact of long-term care. All right, so let me summarize some takeaways. So first, absent the reduction in Medicaid spending per member per year, state-level trend would have far exceeded the target. So that our coming in right at 3.2% was really just because of Medicaid, and largely because of Medicaid long-term care spending. Our commercial trend of 9.7%, this is sort of a tale of two cities. 9.7% is way, way above the target. But compared to our neighboring states, it looked better. So Connecticut grew in the commercial market a whopping 18.8% in 2021. Okay, so Rhode Island was almost half. Massachusetts was much better. Massachusetts was 11.6%, but that's still 2 percentage points higher than Rhode Island. So I think we should feel pretty good about that and recognize that a large part of that 9.7% was rebound from the absolute drop in spending the prior year. Three, hospital outpatient spending led state-level spending growth across the markets. We saw that. And then, as I noted, retail pharmacy was not a significant cost driver in 2021, but it certainly has been over multiple years. And so, for that reason, the Cost Trends Steering Committee has decided to pursue development of a pharmacy cost growth mitigation policy as one of its priorities for 2023. And Maureen's going to talk a little bit later about what those strategies might look like. I'll say that the steering committee has not yet begun deliberation, so you're having a pre-deliberation educational presentation from Maureen later on. I'll also say that we have more insight now into pharmacy spending than we've ever had. With the assistance of EOHHS and their analytic consultant, Friedman Healthcare, we now have some dashboards that let us see exactly what's driving pharmacy spending in both retail pharmacy and what we term medical pharmacy, which is physician-administered drugs. And I'm going to provide you with a preview of these dashboards shortly to give you some sense of their utility. Okay, the last information on performance against the target is at the insurer and ACO and AE level. So that's what I want to share with you next. So I'm going to share the performance by market. I'm going to start with the commercial market. So let me explain these data to you. 4 commercial payers in the market submitted data, and we assessed their performance against the cost growth target. You can see at the top here that we depict the performance using confidence intervals. So those lines tell us where we confidently believe actual performance was, because even though we know the actual rate, we also know that there's a lot of random variation that happens from year to year. And so a plan with a very large population is going to have a smaller confidence interval, meaning we're going to be more confident in the accuracy of the rate that was calculated. A plan with smaller enrollment is going to have a much wider confidence interval. And you can see that here, that Blue Cross has a fairly tight confidence interval and Tufts has a very broad one. But all of these confidence intervals exceed the vertical line that represents the cost growth target, which is 3.2%. So this means that we can have great statistical confidence that the commercial market trend for all 4 insurers exceeded the cost growth target for this year. If we look at the Medicare Advantage market, 2 carriers, Blue Cross and United, and both of those with trends above the cost growth target. And finally, for Medicaid, a different picture. So 3 insurers, and you can see in this case, they are all below the cost growth target, and that's not unexpected given what we reported at the market level. Again, the size of the confidence intervals vary quite a bit because enrollment across the 3 plans is variable, but all of their confidence intervals fall below 3.2% and do not cross that line. And then finally, just a note. CMS has a financial alignment initiative, and Rhode Island participates. So there is a plan that Neighborhood Health Plan operates titled Integrity. It is the market because there's just one carrier with one product in it. It combines Medicare and Medicaid funding, and the trend for this product was 4.5%. It's a very high spend population and a relatively small population. Okay, last, let me share provider performance against the target. A note about this, I'm not going to be sharing trend rates for ACOs and AEs today. We have data for them, but we found out relatively recently that the data submitted by one of the carriers needed corrective action for how attribution was performed. And so we recently received updated data and we're analyzing it now. What we are confident about is whether or not the organizations did or did not meet the target, but the actual rate we don't feel certain enough about to share those data today. Those data, though, will be shared with the forthcoming report that OHIC's going to be publishing shortly. So you will see the actual rates for ACOs and AEs in that report. So today I'm just going to share with you an assessment of did or did not meet the target, but not the actual rates. So in the commercial market, 4 ACOs and none of them met the target. There are other ACOs in the state in the commercial market, and you can see in the bottom left corner of the slide, they are listed. We didn't report them because they did not have enough attributed lives to meet a minimum threshold so that we could report their findings with statistical confidence. Okay, but there are other entities that have commercial covered lives, just not enough of them. The Medicare Advantage market, the same. 4 did not meet the target. Again, there are other ACOs that are in the Medicare Advantage market, but their attributed lives count didn't meet the threshold. And then Medicaid performance. So 4 met the target. You'll see for 2, for Prospect and Blackstone Valley, it says unable to determine. That's because their confidence interval crossed the cost growth target at 3.2%. So we can't actually be certain whether or not they met the target because the confidence interval crossed the target. Okay. All right, so the last piece of information I'm going to share with you is something that we're sharing for the first time. So the Cost Trend Steering Committee endorsed the idea of reporting on quality performance for the first time as a complement to reporting on spending growth. So the data that I'm sharing today takes 7 measures that are core measures in OHIC's aligned measure set. Let me explain what core measures are. So these are measures that have been identified as appropriate to include in all ACO contracts, all commercial ACO contracts. There are separately a group of menu measures that can be selected by payers and ACOs at their discretion, but the 7 core measures are expected to be implemented in every contract. In addition, EOHHS has voluntarily decided to adopt those same measures for their contracts with AEs. So we can report performance for both the commercial and for the Medicaid market for these 7 measures. The way that the data was collected for this reporting is it came from commercial insurers for commercial ACO performance and came from EOHHS for Medicaid AE performance. The following slides have statewide performance, and we compare it to the 75th national percentile and to the 90th national percentile. We're not sharing data at the individual ACO and AE level, but again, that information will be in the forthcoming report that OHIC will be publishing. So here at the market level, first, commercial performance. So you can see the national benchmarks for the 75th and 90th percentile, and then Rhode Island commercial market performance. All of that green means that performance exceeded both the 75th and the 90th percentile for quality in the United States, with one exception. For A1C control less than 8%, the performance was above the 75th percentile, but not above the 90th. All that green also means really good quality in Rhode Island and something we should all feel really good about. Okay, this is really impressive performance to be above the 90th percentile for all these measures. Now, you know, this is only a group of 7 measures, so this does not tell the story about the totality of quality of healthcare in Rhode Island. But for these measures that have been prioritized because they've been made core measures in the aligned measure set, it's impressive. Oh, the last thing I'll note, you're probably looking at this and saying, but Michael, that's more than 7 measures. The bottom 3 rows, that weight assessment and counseling, that's 1 measure, but it has 3 component elements. For the Medicaid market, it looks a little bit different. Here you can see some green, but some red. So performance for Medicaid compared to national benchmarks is still far better than average performance, but it's not as good as it is in the commercial market. And this does seem to suggest an opportunity for equity improvement in Rhode Island because we've got a gap here, at least relative to national benchmarks in terms of performance for Medicaid and commercial. I will also note, though, that this is 1 year of data. I noted that earlier with regard to spending trend. And so we shouldn't run too much with 1 year of data because I know that in prior years for at least some quality measures, and this isn't all quality measures, that Rhode Island Medicaid performance has been above the 90th percentile. So it's important to look at multiple years of trend, but at least for 2021, there's opportunity for improvement in equity between the 2 populations. Okay, and there I am going to stop so we can take some questions. from Howard or from anyone else.
Okay, I think it's on now. So we're going to move to questions and answers discussion. Anyone in the room is free to raise their hand, ask a question, react to what you've seen, put out any comment you want. I'll just briefly state before we move to Q&A, and Jessica has a microphone that we can take around the room, is as you can see from what we've just presented, we have built the capacity for the collection, analysis, and interpretation of healthcare spending and quality data within state government. And that's a significant undertaking. You don't build that capacity overnight, and a lot of work went into producing these findings. And as we'll show in the next presentation on our data dashboards, we're taking that to a whole new level in terms of granularity. So I just wanted to reflect for a moment on that. Howard, I know you had a question during the presentation.
Just a technical one. On slide 13, you talk about the % increase per capita, and then slide 21, it's per member per year. I'm just wondering if that per capita is actually per member. Or just a
Yeah, so when we measure, our denominator is the enrolled population, or for ACOs and AEs, their attributed population.
Other questions, reactions? Sam.
Thank you, first of all, for the clear presentation, all the work that went into it. I noticed that Medicaid looks very efficient, low net cost of private health insurance, low and stable trends. If memory serves, that's been true for the past several years. Do you see that in other states as well?
Yeah, in general, Sam, Medicaid spending growth is consistently at a lower level than the commercial market.
Chris Kohler has his hand up.
Thank you, and congratulations to Corey and the team and to Michael for putting this together. On the cost trends, and I guess maybe Michael, this will be directed to you, commercial and Medicare, the big picture, like super high level, seems to be there's something nationally that's going on. A lot of it's related to pandemic, but then you observe that the factors, there were mitigating factors in Rhode Island that made whatever is that big piece not as great. So everyone was seeing big commercial trends, but for reasons the commercial trends were not as big in Rhode Island. Maybe you could repeat the story for Medicare, because I'm not sure if it's the same story in Medicare. And then if that's the case, Medicaid's on its own because of the long-term care. That's the particular policies on that. But for commercial and Medicare, can you help us understand the big factors that might be outs that are across the country, that are national, and then hypothesize, I don't want to say speculate, a little bit on what is it in Rhode Island that mitigated some of those factors?
Okay. So Medicare rate of growth tends to fall between Medicaid and commercial in most states, but commercial is always far above the fastest driver. What we saw in 2021 nationally was a big jump up in healthcare spending, as we did in Rhode Island, and it was driven primarily by utilization, because utilization was so depressed in 2020 when, for at least a couple of months, people almost completely stopped seeking care. So utilization was the story in 2021. Historically, though, is not the story. If we look back a half dozen years, what's been driving spending growth, particularly in the commercial market, has been price. And why is it a little different in Rhode Island? I would say for two reasons. One, obviously, is OHIC's regulation of commercial hospital price growth. But I would also say that I think that Rhode Island has taken the cost trends initiative and the cost growth target seriously in a manner that hasn't happened in some other states. I mean, I would say in Connecticut with that 18.8%, they have a relatively new cost growth target, and I don't think that it's been embraced within the state yet. And I think it has been embraced to a greater extent in Rhode Island.
And then are you going to, thank you, are you going to do, or do you have the capacity to do pricing utilization trends as part of this, or is that what we're going to see in the dashboard? If it's, you know,
Yeah,
that
so
pricing utilization cut is.
Yeah, the dashboard allows us to understand to what extent price and utilization have been contributors to spending growth year over year. Right. And I'm going to give you a little bit of a preview of that. Frankly, all of you, after you leave this meeting today, you can all go do the same analysis that we've been able to do with the APCD, because it's now all in the public domain.
Yeah, and Chris, on the price question, when you're utilizing claims data, it's important to remember that when you look at a price per unit metric, you're not able to really disentangle fee schedule increase from mix. So let that obviously contextualize the data that you're viewing on a dashboard, whereas what's on a fee schedule and what's negotiated behind closed doors in private negotiations in a market-based system is something that is also very different, and is something that's controllable by market participants, right? That's the one thing that we can control at the outset of any given year. What's the price on the fee schedule? Then utilization happens, then clinical decisions are made in terms of what type of mix-up services, and people go to the doctor and they go to the hospital, and so price is very important, and we hope that these dashboards will help give the public some sense of that, but I wanted to make sure people were aware that it's not, there are different angles to price.
Yeah, the dashboards really contain payment per unit, not price per unit, and it's an important distinction Corey's making.
And one analysis before I go to Teresa Paiva-Weed and then Dr. Mark Jacobs is the analysis we haven't done is just how suppressed was the base in 2020 in these other states relative to Rhode Island. To some extent, your 2021 value is going to be driven off how suppressed your base was, and everyone's base was suppressed.
Yeah, although I will say across the 3 New England states that have cost growth targets, the decline in spending was almost exactly the same in percentage terms, but the rebound was not.
So, Teresa.
Thank you. First, I want to say thank you to both of you and to all the staff for a terrific presentation. Second, Chris, I want to say no more than one health insurance commissioner in the room at the same time. And finally, I think I'd hearken back to what this group kind of originated, and I can't help myself being the ever hopeful optimist, and that is cost trends. And kind of picking up on what Chris Kohler was saying about all the work that's come to get us here. And we did a little bit of math over here, and I think if we look at a 4-year trend, there's a story to be told there. And I was wondering if you are, as this goes on, going to kind of look not just at year to year, but the trend as well. Because I think if you compare the trend to the target, we really have a great story to tell here in Rhode Island. And that's a result of every single person effort in this room. So that's a question, if you're going to say that, if you had a chance to look at it.
So we haven't, Teresa, because 2020 was so aberrant. I mean, that drop, hopefully we will never see that again for the reason that it happened. So we haven't.
So I guess my question would be, the leap can be in no small part due to the aberrant, but there's another side that we look.
No, I think you're right that Rhode Island should feel really good about the work that has been done to advance affordability over the last few years.
Yep, and I certainly intend to look at this data longitudinally. I hope that this program will continue into perpetuity. That obviously is contingent upon funding, quite frankly, but Teresa, to your point, we have to look at the average trend over time, because there may be years where, for any given reason, we're above or below. For instance, we have to make workforce investments. That's going to cost money, and that's going to get reflected in cost growth, and we're going to have to contextualize that. So, Dr. Jacobs, next.
Thank you. Thank you very much. Great presentation. The data is incredibly, to me, revealing about our healthcare system in the state. concern in particular is about the 0.9% drop in Medicaid cost growth. I think it reflects barriers to access to care for the Medicaid population, in particular primary care, but also specialty care. You said enrollment is increased. At least my knowledge about enrollment usually leads to increased utilization, which leads to increased costs. But we're not seeing increased costs. So for me, the conclusion is there's decreased care. And I think this is something that you did talk about, Michael, in terms of addressing equity. But the other reflector of the decrease in care is the fact that the core measures are not as good as Medicare or commercial. And I think those core measures in particular are a reflection of access to primary care offices, their ability to treat this population. So I think that we have to keep our eye on this going forward, because reimbursement to primary care physicians is for the Medicaid population is not as good as it is for commercial and Medicare. And I think this continues to be a barrier for access.
Thank you. I have a couple of responses. I don't think from the data that we've presented today that we can reach all of the conclusions or at least settle the hypotheses you've put out there, but perhaps over time we can. This year is really driven by a number of aberrations, and one of which that Michael spoke to was the suspension of Medicaid eligibility determinations that occurred during the pandemic. So if you're a person who found your way onto Medicaid in 2020 because you lost your job when the economy shut down, then you remain on the Medicaid rolls today. You may have actually gotten a job in 2021 and accepted private health insurance. So there is a duplication of eligibility and member months in the denominators between Medicaid, commercial, and Medicare. That's why I feel very confident in what I see from the commercial metric and the Medicare metric in terms of spending growth, but it's that Medicaid and state level where you've got that duplication of eligibility and member months within the denominator. But over time, perhaps we can reach some conclusions about that, and the quality data that was presented today is something that we should absolutely take a look at.
Yeah, Mark, I'll add that the depression of Medicaid trend in 2021 we're seeing in other states for the reason that Corey notes, because there are significant numbers of people because of the suspension of redeterminations who are on Medicaid, but they're not using Medicaid services because they have commercial coverage. Yeah. So I think we're actually going to see a bump up in Medicaid per capita spending after redeterminations resume, because all the non-users are going to drop out.
And Medicaid is also able to exert control over the price of services in a way that private payers simply are not, because they're ultimately determined through appropriations and state action. So that's another reason why you may see very low Medicaid cost growth relative to commercial, where prices are privately negotiated, albeit in Rhode Island there's an upper bound on what those price negotiations can yield for hospital inpatient and outpatient services. Yes. Dr. Ira Wilson, and then we'll go to the back.
Just while we're on Medicaid, I think most of us are assuming that the long-term care bubble was low because people didn't want to be in long-term care settings, and so it's a utilization issue. And I just wanted to verify that, and just wondered if you are seeing, or if anyone knows whether there's bumps in utilization that are going to show up later.
So I don't know the answer to that, Ira. So we don't get a breakdown of utilization in these data. We can look at that through the all-payer claims database, but it's not a question that I've looked at.
So we had a question in the back, and I'm sorry, I don't know your name.
I didn't hear the last part of what you said.
Is it also because of utilization or costs relative to the MMP?
The integrity program.
Yes, it would include it, wouldn't it, January? Yeah.
And we don't know the breakdown of between home community-based versus long-term
No, we don't.
Yes. Al Charbonneau?
I'm just wondering that all of the quality measures that I see look to me like they're primary care physician office measures. And I'm wondering if we ought to, as a cross-trend member now, asking the question, should we be considering adding some hospital-specific measures in there? I noticed today, this morning, that all of the hospitals participating in leapfrogging have increased, have improved their performance under the leapfrog system. Whether you rated A or B for safety, but I wonder if that should be an agenda item in the future.
So I think we could talk about it. We started with these quality measures because these are the quality measures that accountable care organizations use in their contracts, and the accountable care organization is the accountable provider unit for our analysis. I am absolutely willing and comfortable through consultation with the steering committee to add additional quality data to this program, with the caveat that perhaps it may not tie specifically to the performance measures on cost that we're showing, but measures of quality and access broadly, I think, have a place in the health spending accountability and transparency program. And follow-up question.
Oh, and just another point, and that is, as you mentioned, the performance relative to everyone and commercial, the cost of commercial, the NASHP data suggests that that's what's subsidizing the lower rates in both Medicare and Medicaid. Marilyn Roberts would suggest that that's what's going on. We've seen the data in the Rhode Island Cost Trend Steering Committee group in the webinar that you put on, and I guess my point is simply, we should keep that in mind.
Thanks, Al. And to that point about the NASHP data on hospitals, frankly, we've never had more data at our fingertips than we do today, between the NASHP data that was created on hospital costs, the data that we have on Rhode Island healthcare spending and quality through this program, and these data dashboards that we're going to show you in a few moments. So I'm happy to take one or two more questions before we move to the next part of our program. Yes.
So, Corey, both you and Michael have both referenced the fact that 20 was an aberrant year for obvious reasons. So I guess I'm a little bit curious why we didn't show an increased rate from 19 to 21, a composite or an average annual rate for the 2 years, to get that aberrant year out of the equation.
We did perform that calculation, just so you know. We just didn't happen to include it in the presentation today.
And I would argue 2021 is still kind of aberrant as well. I'm really going to be looking at 2022. And frankly, 2022 is still going to be influenced by the Medicaid eligibility redetermination process. But 2022 is going to be the year that pivots for us. Are we moving into a period of heightened healthcare inflation or not? And I'm one of the few people in the room that has actually seen the 2024 plan year rate filings. So I have the claims data on 2022, and I will be looking at that very soon. I've made sure not to look at it today before the meeting because I didn't want to share any thoughts on that, but happy to do that later. Yes. Any other questions before we move to the next part of our program? Yes, another question in the back, and I'm sorry, I don't know your name. So that's something that we will be looking at during rate review at OHIC this year for certain. I imagine Neighborhood probably priced something into its rate filing to account for that transition of people from Medicaid to commercial insurance. I don't know if it'll be material enough to show up in our cost growth target analysis for future years, but something to consider. Okay, so Michael, why don't you take us to the next part of our presentation?
Okay, so I made reference to our new online dashboards, and I'm going to give you an introduction to them now. I'm going to tell you how this came about, and then I'm going to give you 3 quick examples to give you a feel of what's available. So the data that we collect for cost growth target analysis is aggregate data collected by the payers. We can look at spending by carrier, by market, by ACO, by AE, by service category, but that's about as far as we can go. So questions about is it Medicaid, long-term care, home and community-based services utilization? We can't answer questions like that. The All Payer Claims Database, however, has the capacity to do that. And OHIC has leveraged it over the last several years to get greater insight into what's driving spending growth. Now, for the first time, it's available to you to do the same thing. So OHIC worked with the state's analytics consultant, Friedman Healthcare, to produce analyses that give us insight into healthcare spending growth. There are new interactive dashboards that give transparency, the like of which does not exist in any other state in the United States. We are first. And so this is a celebratory moment, and I'm going to give you a little bit of a demo. So first, if you want to see the dashboards, right now there are 5 of them on the OHIC website. It's a part of the website called the OHIC Data Hub. And if you go there, this is what you will see. There's a Rhode Island cost trends overview that gives you trend data on an annual basis back to 2017. So you can see spending by service category, and you're also able to see to what extent it was change in payment per unit or change in units per thousand that drove spending in an individual year. There are 2 separate dashboards focused on pharmacy, one on retail pharmacy, one on medical pharmacy. There's one on outpatient and professional procedures, and one on mental health spending and utilization. So first, I'm going to give you a demo of the cost trends overview. This is really the place to start if you want to understand what's driving healthcare spending. So it, as I said, provides trends on per member per month spending, payment per unit, and units per thousand. There are footnotes, and there's a methodology section that helps you understand what's in the chart and where the data come from. You can also look at spending by county and by zip code in Rhode Island and see how it varies, including along all these different variables that I just described. If you hover your mouse over any of the bars, it will give you the underlying data that's represented in the bars. You can also get breakdowns by age category, gender, and service category. And if you want to pull down the data and export it into an Excel file to do your own analysis, you can do that too. Okay, this is all just at the cost trends overview, which is where I would start with any inquiry to understand what's been driving spending going back to 2017. And then finally, as I noted, there is a glossary that defines the terms in the data sources, so you can understand what's in the dashboard. I will note that while these dashboards are being made public, I won't quite call them a beta version, but they are probably subject to some additional refinement. I will say that as I've been utilizing them over the last several months, occasionally I find something strange that needs correction. So if you ever find something that you think looks strange, please let Jessica or me know about it, because there might be, on occasion, something that needs a little bit of tweaking. Okay, so I'm going to give you a little bit of a demonstration into what's possible. I'm going to focus on the retail pharmacy dashboard, and this is a presentation that the Cost Trend Steering Committee has seen. So we're starting here by looking at what's going on with drug spending over time. In this particular graph, we can see that on a PM-PM basis, spending grew 5.3% per year on average in the commercial market. Okay? But if we want to understand a little better what's going on, we can isolate brand name drugs from generic drugs. And when we focus on brand name drugs, the average annual rate of growth, 7.8%. Okay? This, I noted earlier that in 2021 we didn't see high pharmacy trend, but if we go back to 2017, pharmacy is a major cost driver. 7.8% is way above the 3.2% target during this time period. Okay? It's also about 3 times the amount of median household income growth in Rhode Island during this time period. Okay? So a clear threat to affordability, brand drug spending in the commercial market. So where was it highest? Well, we can look at that, and this is a mapping of spending for 20 drug categories, and we can see immunological agents was by far number one, $142 million. By the way, just as a reminder, the All Payer Claims database does not have all commercial spending in the state. It's missing a significant portion of self-insured employer spending because it's not submitted to the APCD, but there's enough data in the APCD, both insured and some self-insured, that we can feel pretty good about the accuracy of what we see here in terms of trends. But that total of $142 million is not the total amount of commercial spending on immunological agents because of the missing self-insured employer data. So this is what it was in 2020. We can look at it for a year later and see, did it change? No, it looks about the same, except immunological agents was up to $177 million. All right, so these are all shots from the dashboard. You can go look at this, right after the meeting. The next few slides, I'm going to show you data that I extracted from other dashboards. Okay, so this is what you can do with it, but they're not actual dashboard shots. So I'm going to look at what was happening in the largest spend drug categories. So these were the 4, immunological agents number 1, but you can see 2, 3, and 4 here. Average annual increases in spending of 7 to 29% for these 4 categories. And this is a period during which commercial enrollment was declining. So the amount per capita was more than 7 to 29% by category. Okay, just phenomenal spending growth in these categories. Let's look at them even further. So there are the 4 drug categories. There's the total amount of spend. So we can look at what happened in price per unit during this time period. So here you see what the price per unit was. Pretty high spend in terms of price per unit. Here's what price per unit was in 2021. So this is really interesting because for immunological agents, it plunged, but for the other 3, it grew a lot. In terms of utilization, this is units per 1,000, and here it was in 2021. So immunological agents, the payment per unit plunged, the utilization exploded. It looks very different for the others, where payment per unit, or we'll call it shorthand price, grew. Utilization either grew or declined, depended on the category. Overall, immunological agents, volume was the spending driver. For everything else, it was price. So what's going on? Well, generally it's price, but something strange is going on with immunological agents. So we dug into it further. What was going on with immunological agents? COVID-19 vaccines. That's what it was. In 2021, huge volumes of vaccines, and they were cheap. So the volume exploded, the payment per unit or the price dropped. Okay? If we remove COVID-19 vaccines, then immunological agents had price as the primary driver of spending. So we just had a distorting effect because of the COVID-19 vaccines. So let's look further at these drugs. All of this is available through the dashboards. So turns out that it's a relatively small number of drugs that represents most of the spending in these categories. So 3 drugs represented 42% of the immunological agents, 4 drugs, 43% of the blood glucose regulators. And in our other 2 categories, it's 5 drugs and 4 drugs accounting for 56 and 42% of the spending. So small number of drugs with a lot of spending. Let's look even further at immunological agents. All right, so 4 top spending drugs in 2021. Humira shows up twice, okay? And there's been a lot written about Humira and how the manufacturer has effectively managed the patent process so that they introduce new versions of the same drug. So what you see at the top, that Humira CF pen, that is the replacement product for the Humira pen at the bottom, but they were both in the market at the same time. So this is the price per unit. These are super expensive drugs. So it's $4,000 to $10,000. Units per thousand, no, not huge volumes. The price per unit for them jumped up significantly over 4 years. Our CF pen wasn't in the market in 2017. It came on in 2019. So what about change in price over this time period? So annual increases of price of 7 to 13% for these drugs. So they've got high price points, and they are growing in price at very high rates. Okay, so the takeaway here, I'm not going to go any further with this little demo. The takeaway here is it's brand name drugs that's driving commercial spending. It's the price of the drugs, and it's two things about the price. The prices are growing at a fast rate for the highest volume drugs. We're seeing 7, 8, 9, 10, 11, 12, 13% annual average growth. And the new drugs are being introduced at very high prices. And the next slide, which comes from Nashby, shows that this is part of a national trend. So on the left, we can see what's the increase in brand name drugs. So nationally, actually, it's a little lower than what we're seeing with these spending drivers for immunological agents. It's about 5% a year. 5% a year is still double what Rhode Island households bringing in as an increase in pay every year. But the price points of the new drugs are just skyrocketing. So two problems: new price points too high and annual increases. All right, so all of this we can learn from the dashboards that you now can all access. The last example I'm going to give is for mental health. So this looks at PMPM trend for mental health services for children and adults separately. PMPM spending for children is much higher and increasing much faster for children than for adults. We can look further to see what's the story between price and utilization. Price is not the story. Price is pretty flat. There was a little jump in price per unit for children in 2021, but those are pretty flat bars. What's going on here is all about a dramatic increase in mental health utilization in Rhode Island. You can see it's for both children and adults, but the rates of utilization and the rate of growth for children is especially high. We can break this down further into age categories, and what we see here is that for 11 to 17-year-olds, we had an increase over 5 years of 70%, and for children 5 to 10 of 68%. What's interesting is that the growth in utilization extends into younger adults. It's only older adults where utilization is pretty flat, and I'll also note lower. What was the reason for the visits? Well, behavioral health diagnoses are not quite as precise as they are for some other medical conditions, but we can see that anxiety disorders was the highest category of spend for both children and adults. Okay, so this was a quick run through, but I want to give you and hopefully I've given you a sense of what is now available to the public as tools to understand what's going on in healthcare spending and underlying utilization and price. There are 5 dashboards up there. I encourage you and your colleagues to access them, and you can be data detectives the same way that staff for the Cost Trend Steering Committee now are, to try to understand what's driving spend, because understanding what's driving spend is a necessary precursor to doing something about it. And now we can understand it better than we ever have before. Okay, so in summary, these were produced by OHIC's contractor. They give us lots of insights, and this has never been done before, and it's now available to you.
Thank you, Michael, for that. So we can take reactions and questions from the audience. I want to just first observe I don't think anyone from EOHHS is here this morning, but they deserve a public acknowledgement for their partnership with OHIC in producing this analysis. It was Friedman Healthcare, who is the state's APCD analytic vendor. And this is really unprecedented. This is information that was previously only available to state staff that we're now turning to the public. We're making the APCD accessible to the people, and that's certainly one of the roles of government, to produce information as a public good. So we hope that you'll take a look at the dashboards on the OHIC website. If you have other ideas for pressing population health or health spending research questions that should be addressed, we're happy to also consider the creation of other dashboards. I have some in mind for myself, and I really want people to utilize this. So go to the OHIC website. You'll see data and reports along the top ribbon, and you can go to the OHIC Data Hub and access the reports. So if we have any questions, we have a few moments before our next presentation. Yes, Dr. Wilson.
Hi. Your point about the self-insured not being part of this, or at least not all of them, I wanted to follow up on that. I haven't followed this as closely over the last couple of years. Where are efforts to permit or allow or induce self-insured plans to participate in this, which of course would make the database even more valuable?
So I am not sure that I can report any additional effort since the last time we confronted this issue. There are a lot of self-insured groups that are in the all-payer claims database, government-sponsored plans like the State Employee Health Benefit Plan. The municipalities, as I understand, are in the database because there isn't an ERISA preemption there. But if any of you represent self-insured employers and you're not sure if you're in the all-payer claims database, contact your plan administrator. If you're not in, tell them you want to be in. And don't let them charge you a fee. Al. The Gobet decision.
Well, that came out, and at about the same time, self-insured employers were being quoted some substantial pricing. Previously, they had shared their data, and there was no cost to it. So I personally would support the idea of self-insured employers being without, as you say, without a fee. And we'd be happy to bring the group together. We could talk about that, but once again, without the fee. But the number is quoted, as I understand it, I remember some number like 150K or something like that per
Yeah, and I think, if I'm recalling the number correctly, I think we lost about 40% of our self-insured population that had been contributing to the database before. So they were in the database before, and after the decision they left, but they can come back anytime.
So, Michael, just one quick question with respect to what you see in self-insured employers versus fully insured. Do you see any, are there enough self-insured employers in the database for you to just say, oh, look at the difference in performance between self-insured and fully insured?
So, Ira, you did an analysis, right? A pre-post Gobet of the APCD where you compare the fully insured and the self-insured.
A little bit older, but those two populations, and I think this is what your point is, are actually quite different. And so I don't think we can necessarily look at aggregate data without separating them, because they are different, at least in our minds, right? Because this is the data we do have includes both fully and self, and we don't know which is which. But I think the real solution is we have to really work hard to try to change some subtleties of how Gobet is actually understood and implemented. Now it's the Department of Labor, I think, actually, that has the say over this nationally.
Yeah, to Ira's point, we can't pull them apart in the all-payer claims database, Al.
I don't know, as a clinician, it strikes me that, at least in my experience, physicians don't practice differently based on.
No, they don't, but the plans cover different things in different ways. And also, they're different, the risk profiles of the individuals who are self-insured versus non-self-insured is different because it represents company size.
Any other questions or reactions? I was really impressed by the mental health dashboard, Michael. I thought that we use the all-payer claims database in the context of this program as a way to have an insight into cost growth with the intention of trying to reduce cost growth. But there are areas where we want to see cost growth. Like we want adolescents who have mental health needs to receive care. And if they're not receiving care, that's a problem. So the fact that we can also utilize this source to understand emerging areas of population health need is critically important. Yes, Chris.
At the risk of incurring Teresa's wrath, I'll speak up again. I want to underscore from our perspective at Millbank, looking at other states, how much work it is to build this infrastructure. How Rhode Island was really kind of bootstrapped this. In addition to the origins of the ABCD, you were talking about EOHHS, came from Medicaid as they figured out ways to get a federal match to help build the initial collection. And unless you're in Massachusetts, which has made a really big commitment to funding this stuff directly, it's really important for everybody in this room just to advocate for building the infrastructure necessary to do this work. It's hard to do. There's been a combination of private funding, federal funding. Now we've got some legislative support, and it's just, if we're going to keep going on this path, it's great that Troy and Michael Friedman have built this. They need money to maintain it. They need money to update it. They need money to think about the self-insured stuff. And that really comes from everybody in this room speaking up and making it a priority. I know we did that last year with the legislative, so the second run of the legislative piece. The local leadership was really important for making that happen. We got to keep doing it because this isn't a one-time only piece. It's a collective effort, and it's only going to happen if we all stand up and make it a priority for public officials.
Absolutely, Chris. We can't do the type of strategic thinking in healthcare that we have to do without this data, without this capacity to do analysis and interpret it. So I really appreciate that comment. Okay, that's a question in the back. So data stratified by what? Race and ethnicity. So that's where I wish someone from EOHHS was here today, because they've done a lot of work to try to obtain data on race and ethnicity and integrate that with the claims data. It's not presently provided to us in the all-payer claims database submissions because the health plans don't consistently collect it, from what I understand. But they're working on it. But absolutely, talk to me later, and I can hopefully put you in touch with someone that can answer your question. But that's actually really important. I'm glad you brought that up, because I did bring a statistic to share with you all, and I think it's really important to state this in the context of a discussion around why it's so important to try to drive efficiency and improve quality and lower healthcare cost trends. So HealthSource Rhode Island does a household survey every 2 years. It's an incredible resource. Everyone should check it out. A household survey of Rhode Islanders asking questions about their insurance coverage status, their difficulty paying medical bills, just a lot is in that survey result. And there was one question that was asked in the 2022 iteration. The question was, during the last 12 months, were there times that there were problems paying for medical bills for anyone in your household? And the data is stratified by race. And for those of you who've administered household surveys where you're dealing with samples, you have a point estimate and you've got a standard error around that point estimate. And when you begin to cut the data at smaller populations, you have a wider standard error, and it really prevents your ability to reach conclusions about real meaningful statistical difference between population subgroups. But in this 2022 iteration of the survey, the result for African American Rhode Islanders was that 23.6% of respondents responded that there was someone in their household that had problems paying medical bills in the last 12 months. And that finding was statistically significant at the 95% level, shaded in green in the technical compendium. And you don't see a lot of green shaded areas because of that issue around sample sizes that I mentioned. So if we're going to bring a health equity lens to this work, it's critically important that we keep issues like that in mind, and critically important, I think, to your point back there, that we're able to stratify data by race and ethnicity and other meaningful categories. So we have 1 minute left before we move on to the next presentation. I'm happy to take one more question if we have it, and if not, we can move on. All right, so before we move on, I'll just note, Michael mentioned, and I should have mentioned at the outset, that after today, the Office of the Health Insurance Commissioner will be issuing a more comprehensive report. It'll probably follow sometime in the next couple of weeks. The report will have the provider level cost growth performance data in it. It's organized around chapters. I like to think of it as a truly unprecedented report. It'll also have quality data by provider and insurer, whereas today we pooled them for commercial and Medicaid market. And also the slides from today's presentation, the two you've seen thus far and the one you'll see next, are currently on the OHIC website. And I encourage you all to go there and not only check out the data hub and the dashboards, but also download the presentations from this morning. So with that, I don't know, do you want to introduce Maureen? I can do it.
Go ahead, Corey.
Okay, so we're going to move to the next part of our agenda on pharmacy price growth and what to do about it. I'm really thrilled that we have Maureen Hensley Quinn from the National Academy for State Health Policy to present. Maureen can tell you a little bit about herself, but I've just had such a great time working with her over time, and NASHP has really provided a lot to the Office of the Health Insurance Commissioner on a host of issues. And even though I am a NASHP Academy member and biased, the work you do is so meaningful to states. So thank you for coming this morning.
Thank you. I could not ask for a better introduction. Now I'll try to live up to that. First, just thank you all for all of the work that you're all doing. It's been so impressive. I have loved working with Rhode Island and been able to see the growth that all of you have made over time in healthcare costs. It is a very challenging thing to do, and that you all are sort of blazing a path. Other states are watching and learning from you. So I just want to thank you so much. Okay, so about NASHP, I'm going to make this really quick, but just wanted to set sort of some context. It's a national organization that is for, by, and about states. Corey is an Academy member, as is somebody from, I believe it's the acting assistant secretary, or secretary at this point, of EOHHS. And so we really do take everybody's comments and considerations into our policy work, and it really drives where we go and what we do. I'm going to talk about prescription drug pricing, but the reason we work on prescription drug pricing is because states told us, please help us figure this out. It happened back in 2015, 2016. We've been working on policies with states and for states since that time. And I'm going to highlight a couple of them here. But first, just so you know, we do have a prescription drug pricing center. I know this slide isn't great because it's dark, but it really is someplace where we have analysis of what's happening in data, we have policies, and we have legal analysis, which is critical to trying to address some of these issues. So this is snapshots from our website that show legislative tracking that we have done since, I believe, 2017. You can go and look at archived years. I'm trying to remember, this is the pharmacy benefit manager page. There's a lot of bills that happen across the nation in that space, but we have other categories. And then you'll see there's model legislation and model contracts. These were really developed when states who advise our work gave us the ideas for the policies that we're developing. We go to them, we ask what their experiences are, they explain them to us. We ask, what is the problem that you're trying to solve? And then we develop with legal experts policies around those issues. So why focus on RX? In addition to states saying, help us, we don't know what to do in this space, There is a lot of national data. I love that Rhode Island has specific Rhode Island data, but I just wanted to share what's happening in Rhode Island is happening elsewhere. So as you can see, the percent of spending per person, when you look at utilization and price, prescription drugs are leading the pack. So as you can see, over the years, this has been on a trajectory of growth. I don't know how else to describe that. Even utilization, when you look at that second one, while utilization in some of the other areas has decreased, prescription drug utilization has not, and neither has the price. So nationally, prescription drug spending growth has been steady, even in 2020. As everything else went under that sort of baseline, prescription drug pricing did not. It continued very strong, and then as you can see in 2020 and 2021, it continued. And here's the slide that Michael already showed. I will make a couple of points about this slide without getting into the specifics that you already heard. As you can see, the median percentage increase on brand name drugs, we do say moderated. I will say and again, I don't have any data to support this, this is completely anecdotal, but as we saw states take a very big step forward in understanding prescription drug prices with different transparency programs, there were a number of states that passed that in 2017, and in 2018 they started being able to share data, and we could see how that helped affect the national trend as there was more attention on what was happening with prices. This is after launch. We know launch prices can be extremely expensive, but as you can see, what was happening was they started increasing. We saw that happen with insulin. We saw that happen with EpiPens. We're seeing that happen with drugs like Humira. I will just flag, when you can shine a light on some of this and highlight what's going on, that has helped moderate some of these prices. And then the launch prices, as you can see on the other slide, are just crazy. I will flag, as we started working with states, they said to us, we need to affect both the launch price, but also what's happening after the launch price. And so the policies I'm going to share highlight that. And then this is just a closer look at what is driving, and you already saw a slide on this from Michael, but taking a look at Medicaid data, and this is outpatient prescriptions, looking at specific drug groups, biologics are the ones that are driving most of the spending. And it is true, biologics are life-saving drugs. Science is taking this in places that we don't want to stop, but we need to deal with the price of some of these, or people won't be able to access this important care. So as you start looking at how do we affect drug prices, this is the flow of products, funds, and services. So where is a state or a payer or whoever supposed to enter in to affect price? It's just a morass. And in some respects, it was built this way purposefully, and in some respects, there really are important, critical things that are happening across this crazy scheme, but understanding sort of the flow of where price can increase is an important piece. And the data that Rhode Island is already collecting and examining can help with this. But I'll just say, as we look at what state interventions have been, you can see from 2017 through today, or I'll be specific, the end of April, where a lot of state activity has been specifically on transparency to better understand the supply chain, to better understand what we're talking about. Is it launch prices? Are prices increasing? Is it PBMs? Is it health plans? Is it manufacturers? And then really digging into pharmacy benefit manager oversight, transparency, some regulation to try to affect the growth along the supply chain. I'll also share that one of the reasons why PBMs are such a popular place for states to focus is because there's an infrastructure in states to try to do this. So your departments of insurance can help insert themselves into places where it's much harder to affect manufacturer price. The manufacturer is likely not here in Rhode Island. It's a worldwide market. And so as we talk at NASHP, we're not trying to highlight in showcasing this that PBMs are the only issue within this whole scheme. You saw how complicated it is. But states, the first thing they'll usually say to us is, who's in charge of this policy? Where will this live? Who's going to provide oversight? And because departments of insurance are there, existing, have some oversight of fully insured plans, and plans contract with PBMs, you sort of see where I'm going with this. That's why there's been so much attention. And I think that attention has been helpful, but we've also learned from all of this, it is the price. So you can affect what's happening in the supply chain, and I'm suggesting that states should examine what's happening in the supply chain, but it is the price that's driving all of this. So this is sort of the overarching bucket of where sort of states are, how they're approaching these things. Transparency, Rhode Island is already way ahead of the game on that. Supply chain oversight, that is helpful, but it is only so helpful. And now, truly, a number of states are looking at affordability measures. And I will say it's not a blue state or a red state issue. We've seen states, very red states, pursuing legislation that affects price, and we've seen blue states doing it. It is something that I already shared is across the country, and so it really doesn't know political parties. Here's a quick overview of some of the different ways that states are trying to affect lowering price. Creating prescription drug affordability review boards. There is infrastructure involved with that not every state wants to invest in. Not every state necessarily has the capacity or the resources to. Implementing reference rates, we think holds a lot of promise, and I will go into that in more specificity. Penalizing unsupported price increases, that gets at that slide where we showed even after launch, prices can rise. Prohibiting price gouging, and then using Medicaid models to lower state spending. So reference-based prices. Everybody knows foreign countries to the United States get much better deals on their drug pricing. There's a lot of reasons for that. What we're talking about with this model, we first developed a model for wholesale drug importation. That is extremely complicated to do. There are, I believe, 9 states now that have passed that law. There are states deeply engaged in trying to work out the details to import drugs from Canada, and we are supporting that effort. But as we started walking down that pathway with states, we realized importing the price rather than the actual drug was a much more streamlined way to go. And so that's what this model attempts to do. And we have been working with states to understand what the savings could be. This implementation structure that is highlighted here, using the state employee health plan, identify your 250 costliest drugs. They have that data. Honestly, as you heard earlier, your top 10, that might be all you need, to be quite frank with you. But you can get a lot more data from your state employee health plan. And then crosswalking to Canadian prices, you can see the savings. The Canadian price becomes the upper payment limit if you should pursue this policy. And that payment limit could be for all payers except Medicaid. Medicaid has a very different structure. ERISA plans or the self-insured could opt in. It's true, you can't dictate what their payment limit would be, but we've talked with a number of different self-funded plans who said we want to benefit from a lowering cost policy as well. And then it does protect local pharmacies, because what you're doing is setting an upper payment limit. You're not affecting what pharmacies necessarily get reimbursed from manufacturers, PBMs, and others. This is an example of real analysis that we've done for a state. It's not Rhode Island, but I will just share. These were the top spend drugs that they gave us. So we looked at comparing that to the Canadian reference rate, and I will tell you, we went down to the milliliter and microgram of the drug to make sure we were comparing apples to apples. And as you can see, there's a 76% savings. Same drug, you're just using an upper payment limit that Canadians use. So many of you may have paid attention to the fact that the Inflation Reduction Act included lowering drug price policies for Medicare. And I know there was a lot of hope that that would extend to the commercial market. In the federal law, it does not. However, we worked with states who said, why can't we make that work for our state? So we adapted our model for reference-based pricing to incorporate what CMS is going to negotiate with drug manufacturers for Medicare, so that a state could use that as a reference-based price as well. So the process is only starting. CMS is staffing up now. We know that they are going to compile a list of drugs that meet criteria that fit the federal law. That at first it's going to be 10 drugs, which I know everybody wished it was higher, but 10 drugs to start out. They're going to be looking at the maximum fair price. They're going to work with manufacturers to negotiate these prices. They are going to publish that ultimate list. I don't think we'll know all the details of how that negotiation goes. And then there will be strong penalties for lack of compliance. And we want to help states leverage some of that. So we are jumping to conclusions here, but since these drugs end up on everybody's list of highest cost, we anticipate that these will be some of the drugs that CMS negotiates with manufacturers. So the two pieces together are what we're supporting some states to attempt to move through their legislatures. So looking at a reference to Medicare's maximum fair price and looking at Canadian prices as an upper payment limit for the state. Okay, so what do we do about those after launch that increase over time? We have created a model that prohibits unsupported price increases. Under this model, manufacturers are fined for certain price increases that are unsupported by clinical evidence. So how can we tell if a price increase is not supported by clinical evidence? I'm not sure if folks know about ICER. It is the Institute for Clinical and Economic Review. They are a national nonprofit that reviews drugs annually to understand if their price and their price increases actually can be connected with the increased value of the drug. And they do a report every year to take a look at that. They do work with manufacturers. It's not an aha moment when that report comes out, and they do provide data and transparency about how they get their results. So rather than a state creating their own review, this model builds off of this ICER review that comes out and is shared. So the penalties that are written into the model, and of course can be adapted by states as you need, is 80% of the excess revenue. So let me just share what that looks like a little bit. This is a hypothetical, as you'll see on the slide. So imagine that a list price for a monthly supply of a particular drug was $3,000. And then the next year, for a monthly supply, that jumped to $3,360. So the increase is the $360. That's what we're looking at, not the whole 3,000. So you take a look at this. We had written into our model that inflation was 2.3%. You may want to take a look at that given how crazy inflation has been. However, I still wouldn't equal it to the inflation that we're experiencing right now. And then as you can see, what we're looking at here is when you take inflation into consideration, $3,070 is what the drug should cost. Looking at the excess revenue, you take a look at that. You've got excess revenue of $290. You times that by the 10,000 prescriptions in the state. You get then 12 months, and you've got $34.8 million. The penalty would be 80% of that increase. I know that that was a complicated piece, but I do encourage you to take a look at that hypothesis. So it is really just penalizing the unsupported price increase. That $27.8 million you could use to give help to consumers that are purchasing health care generally. It doesn't have to go back necessarily to prescription drugs, but it could be used for that. We did, here's an ICER report just to give you a sense of the results that they find and that they publish. As you can see, for this analysis, they ultimately decided that there was about $800 million of unsupported price costs across the country. And then we took a look at that and compared it to some states. The states we did use Rhode Island, Connecticut, Oregon, Washington, New Jersey, a number of states that we've been working with in different capacities and also that share some unique circumstances. Rhode Island small, Washington, Oregon larger, you get it. So there are challenges to this, and I'm not going to suggest that there are not, but an increasing number of states are starting to look at these policies to affect price. So Rhode Island won't be alone in this. However, I will say the data and the infrastructure that you already have with this steering committee and your state agencies really does put you a leg up from where some others are. The 340B program. So how many people here know what the 340B program is? Great. I love that because I don't want to have to explain it in detail. So you know that there is an inherent benefit to keep drug costs higher so that the spread that hospitals can benefit from that is an important revenue service is greater. That is an inherent problem in trying to lower prescription drug prices. It doesn't matter what policies you use. Increasingly, a number of states have reached out to us to say, what do we do about this? We don't want to take important revenue away from our nonprofit hospitals. We certainly don't want to take it away from clinics and others who need this to stay afloat. First step, honestly, is to understand how much we're talking about. It's very vague. I can't, standing here right now, tell you that there has been a solid resource of data to explain the 340B program. I know individual entities have that information. I know they are reporting that to the federal government, but it is not available for states. And so understanding what we're talking about, what is the revenue that clinics and nonprofit hospitals are getting from the 340B program would be immensely helpful to understand what lowering drug prices for the whole state would mean for those hospitals. If you pursued the unsupported price increase model and gained savings from all of those millions of dollars, there may be an opportunity to leverage some of those funds to make up for some 340B revenue losses. I'm not saying that that's what a state would want to do. I'm just saying you could have that conversation, and it could be a data-driven, evidence-informed conversation so that you could move forward with that. There are others that are benefiting from 340B within the supply chain. There's pharmacies, but there's also split-party vendors and all of these other things. I think you would want to get down to understand the providers and what they're counting on versus all of the other stuff. Okay, so there is going to be strong stakeholder pushback. It's just real, and everybody understands that. When you start talking about lowering price and lowering revenue, you're going to get pushback. But so really understanding what that means for Rhode Island, using the data that you have, it's an essential way to look at this. And then infrastructure. Everybody needs some level of infrastructure to oversee pharmacy prices and to be able to make sure that the policies that you are passing are being implemented as you had intended for them to be implemented. And every state is going to make that decision based off the infrastructure capacity that they already have, but it's a critical decision point. However, the opportunity is immense. Like the opportunity that states have right now to affect change in pharmacy costs for individuals cannot be undersold. So even though there are these challenges, I have to say the opportunity to help people literally getting prescription drugs, literally making sure they can afford care, helping to stem some of the rising, overarching healthcare spend that's happening in states is just immense. And so I hope the challenges do not squelch your energy to try to look at this as a viable option for cost savings. Okay. With that, I'm happy to take any questions. Yes. Oh, I'm sorry.
Oh, that's okay. Hi, everybody. Can everybody hear me? Hi. So I'm going to facilitate the Q&A for Maureen. Maureen, thank you so much. That was a fantastic presentation. I'm sure there will be lots of questions from the audience. I'm going to start us off with just a few and then turn it over for questions. So the first one I have is based on the data that you shared about launch prices being high, but price increases moderating, and the data that Michael shared around the high price points in Rhode Island, as well as the significant increases. Which of these strategies that you talked about do you think would be most significant and impactful for the steering committee as they begin to undertake the work of honing in on which types of strategies to pursue?
I really do think that the two that we went over today, the reference-based pricing and the unsupported price increase penalty, would pack the most bang for your buck.
Great. Thank you. Okay, one more question. Based on what you shared around many states trying to endeavor in the same pursuit, which of the strategies do you think would be most suited or well suited to a multi-state coordinated strategy across states, and why?
It's a great question. I do think the reference-based pricing holds a lot of promise because you're using a stable reference, so multiple states could all have that same upper payment limit. I will say one of the challenges that manufacturers will pose to states, and I know you won't be surprised to hear this, they'll say, well, we'll just stop providing drugs to your state. If you're in a multi-state compact, that's going to be much, much harder to do. The other thing I'll say, there's no evidence in the way that drugs are supplied in a global market that there's actually chance of that really happening, that a manufacturer will say, everybody else other than, and I hate to pick on them, but everybody else other than Rhode Island gets Humira. I just don't see that as a possibility. I really don't. But if you're in a New England pack, and again, I'm not suggesting that New England should be your states. You could choose states around the country. It's going to be much harder to be able to push back to that and say, so you're not going to give drugs to any of us? And so I do think having that unified upper payment limit that you get from a reliable source, Canadian and or Medicare, for multiple states will help.
Wonderful. Thank you. Okay, questions from the audience? Yes, and tell me, would you like the mic? I'm happy to.
I don't think I need.
Okay.
So thank you, Maureen. I'm from Blue Cross Blue Shield of Rhode Island. We actually worked with sponsors this year to introduce unsupported price increase legislation. Mashpee was incredibly helpful to us, which was
Oh, good.
is here. So thank you on that. But now you partially answered my question. I mean, one of the things we keep hearing is if any of this legislation gets introduced, that the drug companies are going to stop selling drugs or making drugs available, and then people who need them aren't going to get them. And so it sounds like you're not aware of any states
So we're seeing the same thing, and it is compelling. So there's somebody with a lot of medical complexity that has multiple very expensive drugs and a reference-based pricing model, unsupported price increase penalty model. It will take time to build the infrastructure and to implement that, and then for consumers to see the relief. It's a really hard thing to pitch to legislators who get elected and need to be able to run and say, I've helped you right now. But what I'll say is Colorado is a good example of this. You have to have, with all healthcare policy, I feel like you have to have a long-term goal, and you have to help meet people where they are. It's very challenging. It's what makes healthcare, I think, so challenging. But Colorado is doing both. So Colorado has, they've passed wholesale drug importation. That has been stalled at the federal level, getting approval to move forward. They are building a pharmacy drug review board. That takes time. And they are shoring up because there is going to be a lawsuit no matter what drugs they choose. And so they are doing their due diligence to make sure they can support their decisions, while they're also have transparency, that they're tracking trends. They're also looking to give some at the pharmacy support and help to consumers, passing rebates directly onto them at the pharmacy counter, having caps on insulin prices. So there's a way to do both at the same time, but I do think you have to be careful, because you don't want some of your consumer policies to then translate into better costs at the drug counter that get pushed back to the health plan, that get pushed back to higher premiums. So it's really complicated to manage all of these things, but I do think the rebates could be helpful in the short term, while also pursuing a long-term price. I don't want to call it a fix, because nothing is a fix, but solution. And so I think being able to talk about that effectively is critical.
Great, yes.
So on the reference-based pricing, I understand how that could lower prices for payers, insurance companies, but a lot of providers have to purchase pharmaceuticals as part of the services that they provide. What's the impact on the price that the providers pay?
That's a great question. And I do think that we've got some of those issues addressed, because also for pharmacies that are purchasing drugs, and you don't want, so providers or pharmacists, you don't want them to have to purchase drugs at the higher rate and then be reimbursed at the upper payment limit to then bear the burden of that increased cost from the manufacturer while getting a lower payment. There's language in our model that addresses that very succinctly, and it's particular to say that I'll make sure it says provider when I go back, but that the pharmacy should be held to the upper payment limit and not the manufacturer price, to make sure that what you end up getting reimbursed is at the payment limit rather than what the manufacturer price is.
I'm not sure that does it, but I think it's good to recognize that.
Yes, I agree. There is language in there to help protect. I know it's pharmacies. I will make sure there's language specific to the provider.
In particular, there are some providers like hospitals
Yeah.
have significant pharmacy costs.
Yes.
And administering just, as they're treating the patient.
Yes. Yes.
So that's really a particular issue.
I appreciate that issue, and I am quite certain that we've got that addressed in the language. Yes.
I just was curious, I want to make sure I'm not misinterpreting. You seem to suggest that PBM reform initiatives in other states were easily done, and that's why people went there, but maybe didn't have impact. There's a lot of legislation pending this year, and I know as hospitals haven't gotten involved in any of it, but I'm just kind of
So thank you for the question. I don't mean to suggest that regulating PBMs is not an appropriate thing to do. I actually do think it's important to understand the flow of the funds and to recognize that PBMs are in a situation where there can be spread pricing that they benefit from immensely that then gets passed on to the consumer. So I don't mean to suggest that that's not a direction that states should go. So far what we've seen is there are states that have passed transparency legislation to understand the flow with PBMs, and states have shared with us that while important to have that insight, it hasn't affected price. And then there are smaller subset of states, Maine being one of them, that passed PBM reform that significantly connected the PBM to the medical loss ratio of the plan. And so the PBMs as a fiduciary, and I think that language is important for this, as a fiduciary connected with the health plan, being responsible for the 80-20 or the 85-15, if their administration goes above that, to be able to give that back through the health plan to the consumer is important. So here's one of the issues with that. I can't share data that says here is the silver bullet yet, because Maine implemented that in 2020. 2020 was a very strange year for all things related to health plans, medical loss ratio, and other things. And so we need a little more time to understand if that actually has been useful or not. I will also say that we've worked with a number of state employee health plans that have done a lot of work to review their contracts with PBMs to understand if there were opportunities for savings to their health plan and the employees, and a few have found that there are. So I don't mean to suggest that PBMs should not be part of the solution. I think they should, but we haven't seen, like, we have saved this millions of dollars and it has meant this reduction in price yet.
Yes, in the back.
It's a great question, and one that we've gotten before. So the 80%, I don't think there's magic to that number. When we were working with a group of state officials on these models, the reason why not going to a full 100% was to try to avoid what you just highlighted. Like, if there can't be some level, if a drug manufacturer is going to do that, if they are going to increase the price, and they're looking for increased revenue from that, if you take it all, like, how high will that end up going? So the 80% was landed on. I'm not saying that you couldn't do 100%. I'm not saying that, you couldn't do 50%. We, in the group of states, highlighted that, and looking at certain drugs as examples, focused on the 80%, but you can do whatever makes sense. The model is just that. It's meant to be adapted.
Thank you. Yes?
What can be done at the state level to increase the availability of biosimilars as compared to the branded biologics?
I don't know that there is anything at the state level. I would love to be able to say, why not? But FDA approval for those is critically important, and so I don't know that the state has any authority over bringing biosimilars into the market faster or being able to use those faster. The other piece of that is some of the biosimilars are also pretty expensive. And so we have decided, again, with state officials telling us to, that that's, while everybody's excited about biosimilars coming on, that's not where they want to spend their attention and their time, given how little effect they have over that market.
We have time for a few more questions. Okay, I'll ask you one while others
Sure.
are thinking. So you spoke a little bit about some of the strategies that cities can use to respond to stakeholder pushback, one of them being that that manufacturers will stop selling drugs in a certain state. Can you speak to other types of pushback and state strategy responses that, that Rhode Island can be thinking about?
Yes. One in particular is that the state's going to be sued. I can't say that that won't happen, and I can't say that there is a model that can be designed so that that would never happen. I will share with you that as we are developing different models, we are working with a number of different legal experts to develop those. So we are working hand in glove with more academic experts. And then we, last summer, for the reference-based pricing, for the price gouging, we have a price gouging bill as well, and for this unsupported price increase bill, we asked some courtroom litigators to take a look at those for us. And we said, is there anything we can do, understanding that we've met all of the sort of academic thresholds when it comes to language and putting those out there, but what does it mean when it really hits the ground and when states, regardless of how perfect a piece of legislation is, which no legislation is ever perfect, what do you do when pharma sues? And so we did have some courtroom litigators talk with us about, like, here are the pros and the cons, but here's how you could defend against that. Here's how an attorney general could pursue this. And so we do have some supports. Again, we can't be in a courtroom with you, but we do have some supports to provide some attorneys general with some of that information if needed. But
Great.
that is
Thank you.
another very real threat.
Thank you. Yes, in the back?
Yeah, this is really probably not fair for you, but maybe Bailey and others can answer it. When you look at some of the slides, people might be tempted to say, well, pharmacy's not the issue anymore. That you're talking past history. Let's not, worry about all the trauma we're gonna have to undergo at the legislature to get this stuff through. But I asked a particular question. You said that the price was not so much a factor because of large rebates from retail pharmacy, but hospital outpatient was the major area of growth. Hospital outpatient, at least in our Medicare ACO, one of the major drivers of cost is Part B drugs for Medicare or physician-infused, facility-infused drugs. Do we know if that was a major driver in hospital outpatient?
That's a coming dashboard we find.
I can hardly wait. You guys are always giving us teasers. Very good.
Okay, I think we have time for one more question. Yes.
I'll make an observation. So, Maureen, thank you for the presentation. As we observed earlier, pharmacy prices, that's something that the Cost Trend Steering Committee is really trying to look at, because we've committed to meeting a healthcare cost growth target. And the insurance companies and the providers who are around our table are making efforts in their own space to try to meet that target, either through their prices or through how they contract with one another, how they care for patients in the right setting, in the right place. But we're going to need help. We're going to need help meeting that cost growth target. It's going to be really hard to do when you face the inexorable increase in prescription drug prices. So we have a multi-pronged approach going on here. And I think as NASHP has developed, there are a lot of creative approaches that states can take, and OHIC is committed to pursuing those. We will be convening kind of an interstate working group to assess, is there something that we and other states who are interested in this space can do to try to create some collective action around this and maybe agree upon some legislative initiatives in the future to try to create that multi-state alignment to push back against some of the assertions of the manufacturers. So thank you, Maureen.
Well, and thank you for all of your work. I just really appreciate it. And to your point, healthcare costs are multifaceted, and your approach to them has to be too. But I'm excited to be learning from you all, and thank you for the opportunity to speak with you. I appreciate it.
All right, our next panel, I'd like to invite our panelists to come up, please. For our next and last panel for today, we're going to have a discussion of current and future efforts to address the many challenges that our healthcare system is facing. And so that includes healthcare spending trends as well as the infrastructure for care delivery. This is a very expansive topic and a very important one. We have 4 panelists here today who I'm sure have a lot of interesting things to say. We also have only 30 minutes for this discussion. So I'm just going to get right into it and ask our panelists to briefly introduce themselves. Maybe we'll go from inside out, and then we'll launch into discussion.
Good morning, Michelle Letterberg from Blue Cross Blue Shield of Rhode Island.
Hi, Al Caros. I was a practicing internist for 20 years, senior VP for primary care and pop health and lifespan.
Ira Wilson. I'm a physician, a primary care physician who practiced primary care for over 30 years in Rhode Island at the VA. And I'm also the department chair of the Department of Health Services Policy and Practice at the Brown University School of Public Health.
And Sam Salganic, I'm the executive director at Ripen. We're a statewide nonprofit. We're peer-led. Most of our board and staff are parents or caregivers to a loved one with a special healthcare need, and we help tens of thousands of Rhode Islanders every year navigate our healthcare system.
Thank you. So as you can see, we have a very diverse group here. I'm going to start out with a question to Al. As one of the co-chairs for the Cost Trend Steering Committee, can you describe for us the activities that the steering committee has prioritized for the next year or so, and why the committee chose to endorse these activities to advance affordable, high quality, and equitable healthcare for Rhode Islanders?
Sure. Thanks. So the short list that January is referring to, the priorities that we're working on include hospital global budgets, the pharmacy price growth mitigation strategies we just talked about, public health and health equity targets, which we're going to be talking about here, and also primary care. And so those 4 areas of focus really are grounded in the fundamental purpose of the Cost Trend Steering Committee. Many of us are signatories to that compact and to the value-based payment compact that we signed last year. And again, the areas of focus are really, we're working together voluntarily, which is important here. It's a voluntary consensus model to reduce the growth of healthcare spending while maintaining or improving quality and access. That's kind of a short sentence, but there's a lot that's baked into that. Again, controlling cost trend, maintaining or improving quality and access. So we look at that question, and then we looked at the potential use of value-based payment as a lever. And so that hypothesis that value-based payment would help us with cost trend is what drove us to look at global hospital budgets. For those of us who are in that work group, it's been many meetings and a lot of good work and analysis. We're trying to figure out whether or not global hospital budgets might be implemented in Rhode Island, and if so, how. So that's our first area of focus. The second, pharmacy cost growth mitigation. We just spent a lot of time on that, and it's a significant driver of rising costs, even if not so much so in this particular performance year 21 for the reasons that were mentioned. The third area of focus currently, public health and equity targets. That's kind of a natural area of focus for us. We've seen the effect of the pandemic in terms of magnifying the inequities we see in healthcare. We saw some of that in the quality results we were talking about earlier. So that seems like along our third item on the list, a natural area of focus for us. And then lastly, primary care. Been working on that a long time. I look at Chris Kohler, who got me started working with OHIC on that in 2009. look around the room, and I know Dr. Jacobs was there before me. It's a little bit of deja vu all over again, and we'll talk more about that. But briefly in the meeting that we had recently, there was a consensus amongst the cost trend steering committee members that one of the most valuable things we could do would be to assure the well-being of primary care, because we know that's foundational for the goals that we're pursuing. So I'll pass the mic in just a second, but while I have it, I'll just call out appreciation for what I've heard other speakers sort of celebrate here, which is the collaborative undertaking that's been going on in Rhode Island for a very long time. Leaders have come and gone. Areas of focus have shifted, but I think the fundamental values we're driving for and the public interest have remained steady. And so much appreciative to work with everybody and to hear today about all the progress that continues to be made.
Thank you, Al. Michelle, I was wondering if you can comment on these strategies that Al described and talk about how they relate to what Blue Cross Blue Shield of Rhode Island is trying to accomplish as one of the major insurers in the state.
Sure. So these are all areas of priority for Blue Cross and Blue Shield of Rhode Island. And I think, like Al said, there's definitely benefit to collective impact. And even when we are working on these strategies, we're not working on any of these alone. We're working with all of you or your organizations in the room. And so I think about value-based payment. We've been at that for a while. We actually started many years ago with patient-centered medical homes and providing infrastructure support even for EMR adoption, recognizing, you know, primary care practices need a level of infrastructure support if they are eventually to move to accepting risk. And so that has been work in progress over time, and it is morphed, but we continue to be committed to that as one mechanism to reduce cost growth over time. And have moved from, you know, paying for patient-centered medical homes to looking at PCP cap to global cap in some situations. We talked a lot about prescription drug costs. That's 25%, about 25% of total medical costs at this point. Blue Cross has been committed to that. We feel sometimes like we're the lone voice at the General Assembly addressing that, but it's really important. So we've done work on our own in terms of collective group purchasing with other Blue Cross plans, actually participate with supporting pharmacists and patient-centered medical homes, but then have gone the bolder route of recognizing that we really have to address the underlying cost of prescription drugs, and so have been out there with some support of others, but really trying to work at the General Assembly. And then I would, health equity, that's really important. I think we as a state talk about collective impact. You know, as a statewide level, we know that there is a tremendous amount of disparity in health and health outcomes, and so I think collectively we need to work together. There are key measures that we're all looking at, and I think if we can work together to do things like increase rates of colorectal cancer screening, that saves lives. And we actually, one of the things at Rhode Island is, I think, somewhat unique with the pandemic and vaccines. Rhode Island Department of Health collected race and ethnicity data, which we have for 80% of our adult members. We are now, Blue Cross has the ability for members to self-report race, ethnicity, language, sexual orientation, gender identity language, but we can look by race and ethnicity at screening. And so I think we're really looking forward to a new work group with Cost Trend Steering Committee, which is going to pick a few public health equity measures that we collectively agree we're all going to drive towards. And then last but not least, primary care. We have been committed to that, recognizing that is the center of healthcare and wellness for members in Rhode Island, and so remain committed to and continue to work with our ACOs on how to help increase access to primary care, whether it be through primary care physicians or other extenders who support primary care physicians.
It's a lot. Okay, thank you. So I want to turn to the issue of the hospital global budgets. Al mentioned that there's a working group that's been going. Ira, I think maybe you're all part of that working group, but I'm going to direct this question to you, Ira. So as a member of that working group that's been meeting over the last few months, can you explain how a hospital global budget can support the goals that are outlined in the compact around promoting affordability, promoting population health, and at the same time how it can sustain our hospitals? And then can you also comment on what do you think would be a successful outcome of this effort of the Hospital Global Budget Working Group?
In 2 to 4 minutes. Let me just say that work on this global budgeting issue has been ongoing now for about 8 months. It's been as intensive as almost any kind of work group I've ever been a part of. And it also has revealed that this is a tremendously complicated problem. So what I'm going to do is just provide a little kind of a framework about like why would we do this and how might it work. So the first thing is from the perspective of Rhode Islanders, everybody understands how important it is to have a sort of a robust, effective, high quality healthcare system from the hospital standpoint. And you know, coming out of the pandemic, I think the hospitals and the emergency rooms really were heroic in the way in which they responded to the pandemic and really emphasized how critical it is to have a well-functioning hospital system. Let me just say that one thing you may not know is that basically 40% of healthcare spending it relates to hospitals. About 20% of that is for inpatient services, and about 20% is for outpatient services. So you cannot accomplish the goals of sort of a stable, effective, and cost-effective healthcare system without dealing with hospitals. And so that's part of the reason for doing so. The other thing I would say is in Rhode Island, although I haven't actually seen these data myself, hospital margins, if you look at all the hospitals over the last decade, are about zero in Rhode Island. Okay, that is a pretty disastrous prescription for the future of hospitals from the standpoint of consumers. The second point I'd like to make is that why would hospitals be interested in this? Well, they're interested, or at least should be interested, in sort of stability and predictability in their budgets. The way hospital services work is the way almost any service works in the fee-for-service environment, which is that the incentives are to provide more services and higher margin services, not necessarily the services that the state needs or that the residents of the state needs. And so part of the idea is to move from that kind of a volume-based setting into a more value-based setting, putting the hospitals, as it were, on a budget. So they don't have to be out desperately looking for high volume services, but rather can think about what their expenses are and think about what the community really needs. Now, hopefully you can do this in a way which is flexible enough that hospitals can do things like catch up on maintenance they need to catch up on, grow new services that need to be grown, et cetera. But the idea is that has to be done in a way that the state can actually afford. And the third point I would make is that one of the sort of parties at this table that we forget are hospital employees. So about 20% of the private sector workforce in the state of Rhode Island is actually in the healthcare and social assistance sector. And some of those are unionized jobs, some of those are non-unionized jobs, but this is utterly essential for Rhode Islanders as employees, as well as for hospitals and as well as for Rhode Island residents. So there's a lot more that I'm sure you all could ask about, but I'm just going to stop there and try to, after that effort, to sort of just frame why would we do this and who should care. If we do this well, all of those parties should benefit.
Great job of summarizing a very complicated issue in 2 to 4 minutes. So I want to turn now to another priority that Al mentioned, which is the public health targets. And Sam, I'm going to direct this one to you. What do you hope will be accomplished by developing these public health and health equity targets?
Thank you for asking, but maybe Ira, no, you're a tough act to follow. No. I think our healthcare system faces two real great generational challenges. We've spent a lot of today talking about the challenges of healthcare costs and healthcare spending, and we all have read literature on how that relates to how it looked 30 years ago, 40 years ago, or how it looks in other countries that are similarly developed. But there's a second challenge that we haven't spent much time on today, which is the public health outcomes that we're getting in our society. It's not a Rhode Island issue, it's a national issue, whether you look at life expectancy, infant mortality, maternal mortality, obesity, really like core public health outcomes. We are really struggling, and not only are we struggling, in most instances we're getting farther behind peer nations, and in some instances we're actually getting worse than we were in the past. And all this cost trends work is really important, but you've heard a lot. I'm glad Ira highlighted a few things a minute ago where I don't think anyone wants to reduce healthcare spending too much, right? You need a functioning healthcare system. It's a huge part of our economy. We could do our work perfectly, and I think most of us have agreed to a core goal of slow and steady and predictable growth in healthcare spending is kind of what, as a society, we want. We could argue about the details. So let's say we achieve that. Let's say we get growth. We hit our target every year and growth is 2% or 1% or whatever. We'll still have 20 years from now, 30 years from now, we'll still have the most expensive healthcare system in the world as a nation. And if we haven't at the same time done work to improve our public health outcomes and our healthcare performance, we still won't have the healthcare system that we want as a society. So there's a theory of change that's underlying the work that we're all doing. And it might be right, it might be wrong, but the theory of change is that by collecting data, by analyzing the data, by discussing it publicly and transparently, that we can catalyze change that will have an impact on the future of our healthcare system. And if that's true for healthcare spending and healthcare costs, it also can be true for the public health outcomes that we seek to improve. So we're putting a lot of resources into this effort. It's been mentioned a few times today. All the people who have been involved in this, all the time, energy, money, intelligence, all of us sitting here in this room that's gone into the work we've done, and thank you for all of that. But if we keep doing all this work and we're not also thinking about improving our public health outcomes with the same level of intensity and resource and investment, I think that's a real missed opportunity. And so I really want to thank the co-chairs and the steering committee for, in this past year, making this more of a stated target and starting to really do some work to bring the same level of investment and intensity to these kinds of goals.
Thanks, Sam. So building on what Sam just talked about and the need for investment, I want to turn to primary care. And this is something that Al, you mentioned is an area where we really need to focus on and really need to build the infrastructure if we want healthcare quality, if we really want to move the needle. So I'm, as a primary care clinician and former CEO of Coastal, you probably know the primary care landscape better than anyone. I think there has been a lot of effort made over the last decade or so to try and improve primary care, but there are still a lot of challenges, right? 8 years ago when I moved to Rhode Island, I was told I needed to wait a year to get into a primary care clinician. A friend of mine is moving to Rhode Island. It's still the same wait time. So can you just talk about some of those challenges that you think the Cost Trend Steering Committee is going to need to discuss over the next year to really tackle this issue and make progress on primary care?
Sure, thanks, January. Looking around this room, I'm not going to claim to know the most about primary care, but we have all been working together for a long time, and it's interesting because so much progress has been made here with the affordability standards, with the development of advanced primary care and team-based care and ACOs, systems of care, value-based payment in the primary care space. There's been a lot of maturation, and yet in some ways we are still in crisis, right? And for all of us who are sort of inside baseball players in healthcare in this room, you all know that people are checking in with you, seeing what you can do to help to get them into a primary care doc, because, and it's all over the newspapers here in Rhode Island and in Boston, there's a shortage, right? So why would we have this problem? Burnout is clearly a local, regional, and national issue in primary care, exacerbated by the pandemic, exacerbated by the burden of documentation, exacerbated by the fact that primary care providers need to do more and more in prevention. There's also been some great progressive thinking and transformation of the work, but when you start to also learn about and address issues in social determinants of health, that's one more domain that a primary care doc has to work in. So the work expands. We have an aging primary care workforce. The pipeline for new primary care providers, particularly physicians, has been weak, in part because of the burden of educational debt that physicians come out of training with, and the fact that compensation in primary care is often not competitive with other specialties. And then on top of it, we have an aging cohort of baby boomers who are becoming senior into the senior age groups with more chronic illnesses. So when you look at the numbers, I think we have to acknowledge that the numbers are just not going to work. We're going to have to change the delivery model because we've got a shrinking primary care workforce. We have an expanding cohort of older patients who are going to need more care. We have an enlarging scope of work. And so a new care model with even more team-based care, to my mind, is kind of the only way that we can go. We're going to need to have advanced practitioners be more involved, but we're also going to need care managers and clinical pharmacists, social workers, integrated behavioral health. We have to change the model. The numbers aren't going to work otherwise. I think also we have to work on compensation. Primary care compensation has to become more competitive. I think that new payment models that we've been talking about, primary care capitation, definitely making progress here in Rhode Island with that. At Coastal, that's going to enable the potential to improve compensation across primary care and to pay these new team members if we're smart enough about that. We have to look to the professional experience of primary care, I think. And again, there are ways that team-based care can enhance that, right? Because you can have everybody working at the top of their license, but we have to take the volume pressure off of primary care providers because we can't tell them, well, you're only going to see sick, challenging, complex patients in every one of your appointment slots now, without saying, but there's going to be people to help you and you don't have to see 20 patients a day, because 20 of those kind of patients you can't see in a day. So again, a new care model, better compensation. We have to study regional compensation here. We have to figure out how we can be competitive with Connecticut and Massachusetts. That in turn goes to, what are the payment rates? How do we compare to other states? So we have some homework to do, some fact finding, which is a topic for another day. But again, new care model, competitive compensation, and a better professional experience. I think if we don't lean into those challenges, things will not even just stay the same, they'll sort of get worse because those demographic shifts and those workforce issues are both going in the wrong direction. Having said that, I think that there's great promise here. The early implementations of a new team-based care model at Coastal are very well received by the providers. Patients are going to have to look to have a little different experience in the future than what's been historically normative.
Thank you, Al. So we've talked about primary care, hospital global budgets, public health and health equity targets, and the fourth is the prescription drug pricing issue, which we've already spent a lot of time on. But Michelle, I was wondering if you could just comment on this quickly. Obviously, it seems like the thing that everybody is certain we certainly need to address. I think the Cost Trend Steering Committee has discussed this in the past and has tried to move forward legislation in the past. Based on what you heard from Maureen, can you just comment on what you think what you think we can do differently this time around to be able to move forward with a strategy like this.
Sure. And actually, I'm going to be really quick because I know we've talked a lot about prescription drugs. I would just say I think we have to figure out a way to move forward. Maureen gave us options, but Corey said earlier, there are some areas where we need to spend more money, primary care being one. If we can reduce the spend in areas like drug costs, then there will be money, because what we need to spend in primary care is not going to be, we can reduce drug costs. That still leaves us money to lower cost trend over time. So I think any of those options we had introduced, like I said, the unsupported price increase, that seemed to be a way to get out underlying costs without maybe as much controversy, but multi-state compact or multi-state effort on the same legislation may be a way to go. Looking forward to the conversation. Fortunately, we've got NASHP, so we've got some really clear options on the table, and I would just urge us to get to the underlying cost of the drug, because nibbling around the edges is not going to get us where we need to go.
Thank you. All right, so my next question is for Ira. We've all heard about what are the things that we need to tackle. They are all really difficult things, and we have obviously a lot of stakeholders that are trying to tackle this issue have kind of vested interests in these. But I want to get your perspective as a researcher and as someone who is deeply involved in health policy and care delivery, but and you're sitting at this table, but you represent an organization that doesn't have any kind of financial that's not financially affected by any of the kind of strategic decisions that are made around how to tackle these different issues. So I'd like to get your perspective as on what will be necessary for the steering committee members who bring distinct interests to the table. What will be necessary for them to take substantive action that really will move the needle forward and that really will make an impact moving forward?
Thanks, January. Another easy question.
In 2 to 4 minutes.
So let me just note a couple things. It's true, I structurally I don't have a dog in this fight, but I'm a taxpayer and I'm a citizen, and so this is just a way of saying we all have interests, and we all have to remind all the people who think they don't have an interest in this that they actually do have an interest in this. So let me just not comment on anything that's already been said. So I'm a primary care doctor. I have a dog in that fight, and I think everything Al said is absolutely correct. A more primary care-based system is going to be a healthier system, not only for patients but for people's pocketbooks. But let me just say the approach I would take is one we have to really build on our strengths. And the strengths that we have in this state are multiple, and they're actually developing. And I think many of you saw really some amazing data and some comments on that data and that data infrastructure, to the extent to which those are, well, maybe not unique, in some cases unique, but we are well ahead of the curve in a number of areas. And there are other things that I would call strengths of the state. Our primary care infrastructure, we've had a patient-centered medical home initiative really since 2006 or 2007 or 2008. Our pediatric health outcomes are really extraordinary, even in the Medicaid program, and credit to Kids Count and many efforts related to that. And I'm not going to try to outline all the strengths, but we do have some strengths, and we need to identify those and build on them. But then there's sort of weaknesses or challenges, and I would say that the data infrastructure strengths that we have are potential strengths. We have, this is really a nascent infrastructure. It's not a well-funded infrastructure. It's not a stable infrastructure. But I hope everybody can understand what the potential of this infrastructure is to change the kind of data and evidence we have with which to address the problems we have in the state. There are a couple of other sort of
challenges, and I'm just going to mention one that kind of comes up a lot in the global budget discussions, and Al just raised it. And you know, I want to frame it by saying, just remember, in healthcare, every dollar you save is a dollar from someone's pocketbook that you're removing, right? So every dollar we save from hospitals is a dollar of revenue hospitals don't have. And it's just sort of some people have called it the iron law of healthcare, but just remember, right, when you take something away that you think's good, where this is a savings, well, it's revenue that someone is foregoing in the state who is counting on that revenue. So that's why this is difficult, and let's be upfront about this. In the global budget discussions, those discussions have been transparent. People have been willing to kind of put themselves to talk about their real issues and real problems. I hope that continues. The thing I want to mention, though, is the really interesting phenomenon about cost of care in the Northeast. So the Northeast is the highest per capita cost for health care in the country. Massachusetts, these are 2020 numbers. Massachusetts, number 4. Connecticut is number 9. Rhode Island is number 13, right? So this is a high-cost region, and one of the challenges we have is when we try to cut costs, we are competing with states. You heard about the commercial cost increases in Connecticut and Massachusetts, right? Where do those increases go? They go to providers. Right? We have to pay and compete for the providers in those two states. So this is a very interesting challenge. How do we keep being an efficient and lower cost state without losing all our best providers? So this is a regional market, not just a local market. So this is one of the interesting challenges we have to face. So I'll just stop there, but close by saying, you know, all of the people who I have interacted with over my almost 15 years here in this state lead me to believe that the kind of communitarian mentality that is necessary to do this, people give up in order for the common good, is here. And I think the potential is great. And I'll just say that the biggest thing I worry about is what Sam talked about, which is that we're not going to pay enough attention to the people who are the most needy and have the lowest incomes in the state.
Thank you, Ira. I am always amazed to see the number of initiatives that Rhode Island takes on a voluntary basis that actually get done. So appreciate those comments. My last question I'm going to direct to Sam, and this is sort of, you know, Ira, thank you for the reminder that we kind of need to bring it back to the people. So I'm going to bring it back to the people and ask Sam, as we move forward with this work, what are the things that we need to be doing to make sure that these cost mitigation strategies actually end up resulting in affordability for consumers and employers?
Yeah, thank you. I won't claim to speak for the people exactly, but you know, I'll start with the very unoriginal observation that affordability is very hard to define and to describe. It's obviously relative. And along a couple dimensions, right? Different people can afford different things, but also in our healthcare system, we have a lot of different players and stakeholders that are paying for healthcare in different ways, right? We have premium payers, we have sort of the patient/consumer, and we have government. And affordability is a conversation that looks very different from those different perspectives. Without trying to sort of come up with a good definition, I think it's obvious to all of us that if healthcare costs continue to grow the way they have the past couple decades, for the next couple decades, that it will become less and less affordable for all of those stakeholders. So how do we sort of bring consumers, patients, consumers, which I was interesting that you left out all those rules that you have as a taxpayer and as a provider. You left out that you're a patient too, and we all are. So how do we bring patients and our own perspectives as patients into the conversation? I think two things. One, I mentioned earlier, is we need to keep talking about making, in addition to making our healthcare system more affordable, at the same time, always in the same breath, we need to talk about making it perform better and not just talk about it, but actually work on it. And I think that a lot of patients, while of course they care about what they're paying in premiums and what they're paying in copays, they also care how long it takes them to get into a primary care provider, whether their providers are able to communicate with each other effectively, so on and so forth. The second thing that I think is important to remember, and this is going to sound really obvious, but I think we forget it a lot, is that for the average sort of patient or consumer, when they think about affordability, they're talking about their out-of-pocket costs. They're usually thinking about their copays and their deductibles. And I know we all in this room know that that is a very limited way to think about healthcare costs. It's a very small part of the picture, but it is the most important part of the picture for the average consumer / taxpayer / voter. And I'm glad that we spent a lot of time today talking about pharmacy, because I think that's a great illustration of another real missed opportunity. We have, I think it was in 2019, we passed a law in Rhode Island limiting copays on insulin. There's another law this year that's getting serious attention to limit copays on certain high-cost specialty drugs. There's a whole community of people working on those. And then in this room, we have a community of people working on this sort of total cost problem, unsubstantiated price increase, reference pricing. The groups of people don't seem to overlap or intersect. And this is not an either or kind of thing. This is a both and. I think there was some confidence expressed earlier that reference pricing, kind of a law over time, would make drugs more affordable for consumers. I actually don't know that that's true. I would have a hard time supporting a law that says that we're going to pay Canadian prices for drugs that doesn't also say that consumers will pay Canadian copays, for example. So I think it's important that we keep remembering what actually will activate the consumer and bring them into the conversation. And it's great that there's a lot of opportunities to do that.
Thank you. All right. We have time for some questions from the audience. Anybody have anything they'd like to ask our panelists?
I have two comments. First, Al, I think you described the situation in primary care beautifully. You've outlined almost every one of the problems that I think we're facing, and I think that we have to find solutions. I would add one aspect of it that hasn't been discussed. I would like to bring Brown Medical School to the table here for a conversation. I think that we have to look at who gets admitted to medical school, what the mission is of those people who are going to medical school, if they're being presented with the right orientation and role models towards primary care, if they opt for primary care, what's their experience as they go into the community, what training programs do they go to, and in those training programs, how does it happen that they suddenly lose interest in primary care? And where do they end up practicing? So the supply chain, in a sense, is something I think we need to look at, and we have a tremendous resource here in the state that I think we can work with to improve the primary care numbers. The second comment I would make has to do with our hospitals. I would say if there was a business that had a zero margin, that business has a problem. It either has a bad product or a bad business plan. I don't think our hospitals have a bad product, but I think they have a bad business plan, and it's not their fault. They were never designed to take care of decompensated chronic medical illness. I think that they're burdened with that and not designed for that. So we need to look at both primary care and other healthcare means of treating chronic medical illness in the outpatient setting. And then I think we need to find a way to, if they go into the hospital, quickly offload them into more appropriate facilities in the community where they can be cared for on an ongoing basis. That would relieve a lot of the pressure so that our hospitals can do the things that they're designed to do and provide them with a business plan that allows them to make sense of the economics of that.
I mean, I appreciate those comments. I'll jump on the second part because Ira pointed out the issue, I think it was you, Ira, of a zero median profit margin over a decade. And that's just not sustainable. And not only that, but we're really farther behind than that because we know the age of plant here for the hospitals is really way above where it should be, which tells us that there just hasn't been revenue available for maintaining the physical infrastructure and investing in new equipment and the like. I think your comments about the primary care workforce are really pointed too. And again, I'll go back to something I said earlier, which is we need to get a data set relative to the economics of healthcare in Rhode Island relative to our neighboring states and how to deal with that. But I think you're right too that so we have to do that in primary care and relative to compensation and competition for recruiting and retaining talent. Then for the hospitals, we have to think about sustainability, because that word hasn't come up today. But retaining, local control over the systems that deliver care here is something that's actually at risk. And so that comes into this equation too, as we try to basically tease apart and then maybe rebuild the economics, to your point about business model, and to all the attention to costs, where if you can lower cost here, you can invest in other ways. We have investments that have been neglected here in primary care, and I think we'll find out. We'll get all the facts. Not everybody wants to hear it, but if age of plant is way over what it should be, then investment in our systems has been somewhat neglected too. If we have to make up for that, we have to fund that in some way, and we're already struggling with affordability. So we have some complex and compelling issues to look at. And I don't mean to be pessimistic at all, but we have to do it. There's going to be a new level of transparency in the economics of healthcare in Rhode Island if we're going to solve these problems.
Teresa.
I just want to thank the panel, and I think I'd like to just, and maybe the panel wants to comment, but hospitals, as everyone knows, as we haven't advertised enough, but the folks in this room know, are not just four-wall buildings anymore. Many of them are health systems of care, supporting on a lateral basis, significantly financially supporting physicians in the community, the same way that the insurers have been, investing in. The hospitals have laterally significant financial investments in the physicians in the community. And I guess as we go forward, the one piece I would ask that I think is missing sometimes, whether it's global budgeting or cost trends, is a recognition of the hospital's role outside the four walls and the financial support that they provide for those, whether it's a VNA, whether it's services in Pawtucket, whether it's the Providence Center, because I do, at the risk of sounding like certain CFOs that I listen to from this group, the reality is, Sam, at least financially, those things that are losing funding are more often than not the things that go to the very issues you're raising. The issues we all care about, issues that impact the social determinants of health and equity. And so I do think we do need to be mindful, and I've asked the group to be mindful as we go forward, to at least recognize those hospitals that are in fact supporting those kinds of services, gateway, all of them in the community.
Thank you, Teresa. I think we have room or time for one more comment or question. I believe, Chris, you had one?
Yeah, I'm not, I wasn't hoping to be the last. But the comments are really helpful. I would just, and it's, I have to say, like, just using the benefit of history, I'm really proud of the work in Rhode Island, so thank you very much. It's really cool to see. Al, investment in what? I think is kind of a key question. Are we investing in the status quo? I hope that it's investing in some sort of system that is accountable for population health from the home up. And I don't think that's particularly controversial, but when we use the language of investment, we want to make sure that we're investing in something. Second piece I point out is the real opportunity around the silent partner here, which is Medicare. And I hope that you folks are paying attention to payment model innovations that Medicare might be coming out with, which I think is in the coming months, which I think is a chance particularly to inform the global budget and value-based care. And I would say in those situations, don't wait for Medicare to tell you what to do. Chances it actually favors the prepared. You come to them with what your vision is. And then the last thing is just to kind of, given the stresses that you talked about, the regional economy, the question of investment, and I guess this gets to what Sam is saying, if we don't stay together, then who's going to, not everyone will feel the pain equally. And those with access to resources, with the financial equivalent of a doc to call to get me into a primary care doc, are going to be the ones that survive a declining primary care workforce, regional inequities, increasing number of old folks, baby boomers needing more services. And our response to that, to Ira's point, has to be a collective response. Because if we don't, it's going to hit some people more than others, and we'll all be poorer as a result. So, thank you.
Thank you, everyone. Thank you to our panelists. We really appreciate it.
Thanks, January. So I'm going to close us out. I think you could probably tell by now that we could spend a whole day on this topic, but we only had 3 hours. But this very clearly is a public-private partnership to improve healthcare for all Rhode Islanders. I don't think you can come away from today's meeting without reaching that conclusion. It's based on a very durable culture of collaboration, and I'm appreciative to you, January, for observing that in Rhode Island we often take on a lot of challenges and we make progress on them. Despite what you might hear, Rhode Island is actually a leader in strategic thinking around healthcare. We're doing a lot of work. I left last year's public forum feeling very energized about the work and about the future. I'm very optimistic about the future. I'm extremely energized after this forum. I think we can tackle pharmacy prices. We've got to work on our hospital financing, get those systems on a more stable funding basis with healthy margins. We've got to improve primary care, and we've got to improve affordability. That involves trade-offs, it involves data, it involves all of us kind of leaving our stripes at the door, but at the same time realizing that we are patients, we're taxpayers, and we do have real stake in the game. So thank you for attending this morning. There will be a report forthcoming in the next couple of weeks, so you'll probably see another communication from us on that. I understand there's a meeting in here at 1:30, which they'll need to prepare for, so if you would like to do some post-meeting networking, there's some room outside for that. So thanks again, and thanks for coming.